recording? All right, it is 5 o'clock, so let's call the Kittitas County Public Hospital District Number 1 meeting for June 25th, 2026. Order. We have an agenda. If anyone's had a chance to review the agenda, I'll entertain a motion or any changes or modifications.
I'll move to approve.
I'll second. I move to approve. Second by Terry. Any further discussion? All in favor, say aye.
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 Chair will vote aye. That says aye. All approved. That motion passes. We have a consent agenda. If you've had a chance to review the notes for the consent agenda, I will entertain a motion if and when ready. By Bob,
Second.
second by Erica. Any further discussion? All in favor, say aye.
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 I too vote aye. All this voted aye. That motion passes. Now we are to public comment and announcements. Is there anyone here who'd like to make a public comment? So since there are going to be people making a comment, I'll just say we limit to 3 minutes. And it's normal for the board not to respond directly. It does not mean we're not hearing you. It's just this is a chance to hear in this direction. And then we, at the appropriate time, discuss what's relevant amongst ourselves. So just make sure you don't feel like you're not being heard because we're not dialogue. That being said, do we have a timer available to us and a card to even warn people we're getting close? There we go. So each person has 3 minutes. Who would like to go? Who would like to go first?
I'll go.
Okay.
Okay. Just because that way I can get it over with.
Yeah.
Hello, KVH administration and KVH board members. My name is Jennifer Crane. I've been a nurse here at KVH for 19 years. I've ushered in much of the younger generation while working in FBP, and now I'm in clinical excellence to support my coworkers. My superpowers are empathy and compassion. I'm speaking to you today regarding an incident that happened at the beginning to the middle of this month. I did not hear about it from work. I heard about it from a community member in Facebook. In this post, I'm paraphrasing her. This person said she was speaking for a friend who worked at KVH, who was too afraid to speak out loud about how they felt when their pride flag was taken down at one of our KVH clinics. This is what I want to talk to you about. I will skip over the facts, like LGBTQ community has a higher suicide attempt rate, or that they often don't seek medical care because of fear of judgment. As board members and administration, I expect you to know it. So let me read you a few things that you might recognize. Mission: we are community-focused health system providing outstanding personalized care to improve the lives of individuals and families. By removing the flag during Pride Month, you've effectively alienated approximately 7% of our population. By removing the pride flag, you've suggested we do not care for certain individuals. Our vision: all patients, providers, and employees are proud to recommend KVH as a trusted source for personal health and community well-being. For 19 years, I've been proud to work at KVH. I've recommended KVH to many and explained to people how we had some of the best longevity here, which equals amazing medical experience. And today I'm embarrassed to be associated with KVH for their discriminatory act. Respect: these are our values. Respect: we recognize the dignity of patients and staff and treat them with compassion. According to the post on Facebook and from trusted sources in this organization, it was one complaint. One complaint was more important than showing compassion for your staff. One complaint and you folded. We provide excellent safe care for members of our community in a healing environment. You have just shown a portion of our community that they are not welcome here. Service: we promote a culture where the patients come first in all we do. And yes, they're LGBTQ, apparently. Transparency: we are principled, accountable, and do the right thing with openness and honesty. Taking down the flag was a knee-jerk reaction of someone insecure in our own mission and vision. I've seen no apology, nor have there been any discussion with staff about this behavior. In addition, no policy in our system says whether you can or cannot place a flag, patient-facing or otherwise. I searched. But what I did find is a policy stating Kittitas Valley Healthcare is committed to maintaining an environment that is free of discrimination, including harassment based on race, color, sex, sexual orientation, marital status, and so on. Furthermore, KVH will not tolerate intimidating behavior, such as behavior violates our code of ethics, which clearly states that all employees and volunteers will be treated with dignity and respect. I have more. I will let you read it on your own. I will leave you with one last image. There's another place in our state, and they clearly support who they should be supporting. Do better. Thank you.
Thank you. I'm just a little worried with people walking around. I don't want to get a trip on this cord. Give you plenty of room. We need more seats.
We'll go grab a couple.
Other seats.
Oh, yeah.
Just give me a thumbs up when it is.
I'll give all this to you and you can tell us what you should get copies of. All right, so we will continue on with, so go ahead.
I'm here today as a concerned employee, community member, and as a patient. My name's Kristen Avalos, and I've been with KVH for almost 6 years, working in the community relations department and brand and digital marketing specialist. Part of my job is to be in the community and represent KVH, our core values, our services, and our employees. I put messaging out there to prospective employees with our recruiting team, encourage people to work for us and to move here. I have talked highly about KVH and at community events, grocery stores, online with friends and family. Huge fan. This is my dream career and I work with amazing people here. Because of my job, I hear both pros and cons about KVH. They're pretty typical and consistent. But for the past year, I've heard a change. I have seen a shift that has caught my attention. In my role, I'm hearing comments that we're frauds. We represent something that is not reflected in our actions. Our mission, vision, and core values are all upfront. And because of poor leadership, lack of accountability, and keeping toxic employees, we cannot keep quality doctors and employees. You get the sense. I've always believed in KVH's character, so this has been alarming to me. Previously, I would typically disregard it and not agree, but seeing the pattern of internal decision-making has actively damaged staff morale and widening the trust gap. We're losing integrity in our senior leadership. We're struggling with our image in our community and within. I'm sure if you asked any of our newly hired leadership team what they struggled with the most, and it would be trust with their team. We are not currently a culture of respect, quality, service, and transparency and collaboration. We're a culture of fear, retaliation, and intimidation. We are fragmented and we have learned to keep our heads down so we can keep our jobs and not speak up. We will continue to move back unless we hold people accountable, let them do their jobs, and utilize their skills. We are letting personal biases and egos get in the way of our progress. My commitment to protecting KVH's image, brand, and integrity is exactly why I'm speaking up. Discrimination, harassment, and pushing people out of their roles violates everyone's trust in us. I hope the board and leadership will take this time to strengthen our policies and protect our workforce. Our policy changes must be designed to be clear, inclusive, and definitive measures of our progress towards health equity. Anything less is a step backwards that compromises our culture, undermines our community, and violates the law. Thank you for your time.
Ladies and gentlemen of the board, Mallory Marsh, my family and I have been KVH patients for many decades. I spent an awful lot of time at KVH in the CCU with my mom in the past year and had an outpatient procedure done here last August. I can say unequivocally that as an out trans woman, I would have felt immeasurably safer and more welcome at KVH if I had seen things like pride flags, pronoun stickers, pins, or any other mention at all of all people being welcome there. I didn't see those things and felt less safe, less welcome as a result. I want my providers to be welcoming and inclusive and to express that visibly and openly in medical settings. It makes me feel safer and more likely to seek necessary care. There are numerous other ways this condition of safety can be conveyed to queer patients and family members, and a well-trained, welcoming staff is more than capable of making any individual who comes through the door feel welcome. Providers have patients and family members at multiple disadvantages, the primary one being I am visibly queer but have no visually apparent way of knowing which providers are allies and which might be hostile or unwelcoming because of my queerness in a clinical setting. Allowing the display of pride expressions in NIC is a very simple solution to this, and it works in many other business, professional, and medical environments just fine. I look for signs of safety everywhere I go, and KVH should permit their providers to display their own acceptance and safety however they think best. A pride display is not a political statement, but one of human rights. It would be unconscionable to cater to the most bigoted faction of society in order to censor yourselves from carrying the simple message provided by a rainbow flag or lanyard. All are welcome here.
Thank you. Other individuals who'd like to comment?
Hi, my name is Campbell. I'm Dr. Shantae Campbell Nixon. I'm a nurse practitioner who works at a Rapid Access, and I'm the one who put up the pride flag. And I put up the pride flag because I am queer and because I care very deeply about this community. I love KVH. I love Ellensburg. I left my home in Missouri 2 years ago because I was terrified at the current political state of what it was like to be a queer person. Really terrifying to be queer in this day and age. Never knowing, just existing as yourself, never knowing who's going to hate you, never knowing who's might want to do violence to you. I used to sit beside a provider who would go and talk to people at a mental health hospital who had tried to commit suicide, who were trans, because of all the trauma they had gone through, would come back and make fun of them and call them insane. So I am very aware that like healthcare is not always a safe place for people because they've had those experiences, whether they're in Washington or a deep red state like Missouri. These are things that happen. And so when I joined KVH and they talked about like diversity and inclusivity and equality and respect, I loved this place because I thought that they would be here. I knew Ellensburg, I knew that they loved, I knew that was a community, and I wanted to be a part of that. And I wanted to help serve my community. And I was still really scared to come out as queer. And slowly I put this name on my badge because someone told me that somebody has to be first. And so I decided to take the risk of what I would face in what I know is a mixed culture because I wanted to know the patients to know that they are safe. And so I put on this badge and I see it in their faces when I walk into a room of a queer patient and they see my name badge and they see my pronouns and they visibly relax because they don't have to be scared and they can talk to me and know that I'm going to see them as a human being. And that is not something that is across the board. It is not on people to believe the trust in our community. Like we have to earn trust in every encounter. It should not be on our community to just be like, oh, they're doctors, we should trust them. Because healthcare is vulnerability and healthcare is deeply unsafe for different people. It has littered with all kinds of discrimination. And so when I picked the flag, I picked the progress flag because it stands not just for the pride, but for diversity, for the Black and the brown community, for the people we serve who have historically gone through so much hardship in healthcare. It's on us to be trauma informed. It's on us to make changes to make everybody feel safe and to enter every encounter that they are. And yes, I was hurt because the pride flag was taken down, but I've realized since then that this is a symptom rather than of what's going on rather than a thing. Because since then, I have been laughed at about pronouns by a coworker. I've had a provider refuse to meet me in the eyes. There is something going on in KVH that people do not feel safe. That is leading. There is a cultural insensitivity and it needs to be addressed. There needs to be further education. And I am here as a provider hoping that I can work with you to create a better, safe place with KVH for this community. Thank you.
Thank you. Anyone else like to make public comment?
I prepared something to say, but I think other people have already kind of commented on that. I was going to talk about the post that you put up on the Facebook group that I found out as a member of an ally community. And the post was shared by a friend of hers because she was concerned about coming forward with it, which speaks again to the fear of retaliation that this organization still has to this day. That was on June 15th. So this is current practice. Also, when I was kind of looking what I wanted to talk about, I think Jen talked about 1 in 39% of LGBTQ plus persons report negative health experiences, which all leads to higher rates of cancer, chronic illness, and infectious diseases because of delayed treatment and because they don't want to engage in the medical system. Again, nothing is new there. When you look at the American Medical Association's website, when you're looking at how to create safe spaces, the first that they say is to create visual cues that your practice is a safe place, and they specify further down with flags, posters, non-discriminatory statements, etc., pairing with other local groups is what their recommendation is. The flag that was posted, unfortunately, wasn't even posted by KVH as an organization. It was posted by a person. And the fact that we can't, as people, present safe, outwardly safe iconography, I guess, is absurd. And the response when the flag was taken down to people that had spoken up that they were unhappy about it was that a clinic manager just said, as a publicly funded hospital, we have an obligation to remain neutral in public spaces. And one could argue that being welcoming and being neutral are not ideas that are in conflict. A few examples of publicly funded healthcare facilities that actively hang flags and have pride celebrations are UW, Harborview, Airlift Northwest has rainbow badges that they wear on their uniform. And a fellow critical access hospital in Central Washington, Columbia Basin and Ephrata, all actively hang pride flags in their public sphere. So the fact that KVH can't even have individual employees wearing that without it being problematic is deeply disturbing for a community that is supposed to be, hospital is supposed to be representing and serving everyone in Kittitas County.
Thank you. Anyone else who would like to speak at this point? So one comment I want to make, so obviously there's a strong theme here tonight. I would say I was involved in the decision to take down the flag. Let me explain how this came about. Jason and I believe Todd, we learned it was there, and it was identified as a complaint. To me, I wasn't a complaint. It was somebody identifying something that could trigger legal ramifications. And by that, what I mean is in today's world, there are individuals that look for ways to sue other entities to get money. And I know this is way simplistic, and this is what we're going to meet about a little bit later in the agenda. We're going to dive into what this means for the hospital in general and in specific. So if somebody hangs a flag and we don't have a policy for whether or not that flag should be there or not be there, and we leave it up there, anyone in theory could hang a flag that represents what they like or believe, because we have no policy. We wouldn't be able to defend it in court. So I didn't say, Jason, I agree, we should take it down because I don't believe in it. It's because I'm deathly afraid of lawsuits. And our job as elected officials, our fundamental job is to keep this institution financially viable. And so the first thing, this is the first time, I have no idea what Erica thinks or Bob thinks or Terry thinks. We're not legally allowed to discuss it until this moment tonight. And that's what we're going to get into. And Matt's on the screen there, and he'll be part of this discussion. So the first instinct is, let's not have something up where somebody could come in with something really offensive. And if we took that down, we would be sued. And these are very successful lawsuits. I'm very involved with the city. And I don't know, a couple of years ago, they went through some of the stuff, and people were calling in from all over the country with obscenely inappropriate things being said over their Zoom calls because they had to be legally given their time because other people were allowed to talk about what they wanted to talk about. And it put the city in a huge quandary, led to lawsuits, get lawyers involved, trying to figure out how do we allow people to speak the truth, especially from our own community, without outsiders stepping in and things that are incredibly disturbing. Because if you shut them off, they sue you. So again, it's a lawyer. It's a treaty. So tonight, what I said is I want to put on the agenda. Let's look at what our policy is, because apparently we do not have a thorough policy. So the first thing we can do is create a policy. It either is from the board or it's from the senior leadership. Somebody's going to come up with a policy in short order. It's going to begin tonight. Whether or not it ends tonight, I don't know how long the discussion takes. Once we have a policy, now we can talk about the specific issue, the flag and the rapid access area that has, brought before us this thing we need to address. So the only thing I want to make clear is, even though I was involved in the decision to take it down, it was only for legal reasons, not for support or belief of what that is. And I know that sounds weak.
It sounds like you're prioritizing your fear of a lawsuit.
My fears for this, not me, it's as in I'm here to protect the institute. And again, we can't enter into a dialogue right now.
Dialogue, so just.
Yeah, I'm just trying to give you a little bit of perspective. If you don't want to wait till item number 9 or whatever it is with, item 8, and we'll get to new policy.
We all understand fear.
Yeah.
We do.
No, okay.
Yeah.
No dialogue. This is why it came down. This is why tonight it's on the agenda. I hope out of that, we come to something that we feel allows us to move forward with legal strength. So that if we do get sued, we can point to a definitive policy that we all agreed we supported it as an institution. So I'm sorry if that's frustrating for people. And again, I don't like to respond to public comment, but I know this is a very heated, sensitive, and important topic that we need to have a resolution for. We have to work within the legal system, which requires we can only do this in public session. I can't talk with them privately to see ahead of time what they think. We have to come and we have to hear it. We have to go through that process. It's painful and it's incredibly slow when you feel like this should be answered immediately. Just the system's not designed that way. So thank you for your comment. Is there anybody online that wants to comment? Okay, hearing none, we're going to go on to presentations. So first up, we have the Kittitas County Coroner. Corey, welcome.
Not sure where you guys would like me to stand.
Anywhere the area is fine, but wherever you're comfortable.
Okay, thank you for having me. Corey McKean, Kittitas County Coroner. I was appointed into the position when Nick Henderson passed away last October. And I just wanted to step in and fill you guys in on what we're doing in the office and hopefully build some partnerships here at the hospital. We've got a couple programs that I'd like to talk about. I was actually just here earlier today with Pack and Plays for the maternity center. They had given away a couple. But let's go ahead and get started here. As quickly as I can, I'm going to go through what our role in the coroner's office is, what our connection with you and perhaps the health department might be, a little bit about myself, achievements with our, achievements with our team, family support, and vision and partnership. So what we do in the coroner's office, we kind of live in between law enforcement. That's probably about 5% of what we do, where we're investigating deaths that may have criminality involved. There's some type of an investigation going on that is alongside law enforcement, but for completely different reasons. 95% of what we do is investigate natural deaths and report back to the health department. A lot of our job is statistic gathering for community health and safety reasons. So we're building a stronger partnership with the health department right now as well, communicating with them. We have started the child death reviews, which have been required by state statute. We just haven't been doing them locally. We've started that this year with the health department. So as we're working through our investigations, we're at the scene at the house or here in the emergency department. We're looking for how that person was living before they died, what may have caused their death today, but anything that we find during our investigation, if we're doing our job correctly, and if there is criminal involvement, we'll only support the law enforcement investigation, which is separate than ours. So we're trained a little bit differently. We also have some different statutes. We are not required to gain search warrants. I, as coroner, can actually go to the Superior Court and demand a jury from the Superior Court judge so that I can hold an I would do that in coordination with the prosecuting attorney, even though I don't have to, but it's because I don't have the legal experience and expertise that they do. So there's a little bit of bleed over, if you will, or a little bit of crossover in the legal system. I just have different statutes, different state laws. So I'm here to determine the truth. My investigators are trained on not necessarily interrogations, but interviews. Again, we aren't there to determine criminality. We're just there to see if what we're being told happened matches what we see. So we're there to look at the decedent and the body and the scene, and then what we're told by the family, if it matches or if it doesn't match, we'll report back to law enforcement and they can take it from there. We're also building in our office support for families. I am among the first coroner medical examiner offices in the state to now have a chaplain in-house. We just utilized our chaplain here in the emergency department a few nights ago for a couple that was traveling through, and the gentleman collapsed here and passed away. And that left the spouse, who was legally blind, incapable of taking their vehicle to the hotel. So we were able to do that. My chaplain and I were able to get the spouse there to the hotel, and also sit with her until family could come from court. So it's huge for my office to be able to provide family support in a way that we never have before, when you're talking about what we can do for the community and what we can do here in the emergency department to kind of help alleviate. Rather than having family members sitting in your emergency room, waiting room, we can help get them where they need to be, or help get them home if they live locally. And protecting public health, again, it's that working with our other county departments, specifically in reporting the statistics back out. We are seeing a rise in two things recently. The first being suicides of men ages 30 to 60 this year. We're also seeing an increase in our unhomed population, males ages 40 to 55 dying. And we have seen our first, it wasn't a kratom overdose, but it was kratom involved overdose. So we're tracking all of that, and we're reporting back to the health departments. So again, one of the things that we're trying to do here is to build a stronger partnership with you. So what I would like to hear back at any point is how we can help to do that. You know, we're working again with the emergency room, trying to move families out of their Faster For You as their decedents that are there. And we are going to start building stronger partnerships with our organ and tissue donations with partners. I'm not sure how that works with you guys here locally in the emergency department when you have deaths. I know State Patrol, when they have a death on the freeway, automatically notify tissue and organ donation. I'm not sure what that looks like here. So I'd be curious to know more. Again, family and grief support. Part of the training and education that we're doing, we have partnered with Central Washington University, and we've been very active the past year and a half, getting out to career fairs, not only at the college, but also here at the high school. And one of the things I'm really excited about is not just building the forensics interest in our youth, but now we have the ability to get our high school kids into Central. So they're doing Running Start, and they can get a couple years of college while they're still in high school. And they can do pre-med at Central now. That's a newer program that they have going there. Not just the forensic certificate that we've been working with, but we can do pre-med there now. And we have recently partnered with Pacific Northwest University out of Yakima, where these kids can now go from pre-med at Central to medical degrees at PNWU. And we've had 3 of their students attending autopsy with our pathologist recently in the last month. So I'm super excited about getting this information to the kids that are local. It's cost effective. It's completely achievable for our kids to actually that want to go into the medical career as doctors to do this, and anything that my office can do to help that happen. We cannot take interns before they're 18 years of age. They have to be 18 and have graduated high school. But if they're in START and if they're at Central, we can offer through the forensic certificate programs, which the pre-med students through biology would meet the requirement. We can offer college credit through Central with our program. So that's super exciting. And again, we're just building on that compassionate service and trying to make sure that we're supporting the families in a way that we never have before. So we are training out our investigators to call upon our chaplain. We're also transitioning our office personnel into a liaison. So that first person that you speak to when you're a family member calling the office is now not just an administrative assistant, but has compassionate services and grief support systems, education and training. And she can be the first person to offer referrals to those services, as as well as be a voice for the families when they don't feel like they're being heard by law enforcement or perhaps by another member of the team that has touched upon them during this death. Again, my job, my role, yeah.
I'm gonna ask that you skip these next two slides.
Okay.
It's too close to stuff that would be connected to an election, which we need to stay away from.
Okay, sure.
Thank you.
Yeah. That was just about me, but that's okay. So one of the things that I was brought into the office to do was to achieve accreditation with our international association, which I did. It was a 5-year process to get the policies written, to get our staff trained up. But Nick Henderson wanted that done and he hired me to get it done. We have that. I am maintaining accreditation. Part of that is we have 22 national standards that have been created. We now have to adapt to. So we'll be updating our SOPs to do that, to maintain accreditation. So I have also been very actively involved in writing grants. I've been successful. I've written 3 grants and I've been successful in achieving all 3, which have been able to pay for salaries for our investigators to be nationally certified and pay for my salary. That's
Matt, can you jump in here real quick? It feels like when she's using the I term, it's making me very
oh,
nervous.
okay. Sorry.
But let Matt speak for a second.
Okay.
Do you have a comment, Matt, or a thought?
Can you hear me all right?
Yes.
I don't know. I'm a little uncomfortable with the timing is all,
Okay.
but
Yeah.
just because of the election coming up and the fact that it's contested, and I certainly wouldn't want the other person who's running to think that someone got extra time. Even though they could come and give a public comment, they'd be limited. So it's just something to keep an eye out for, please.
Okay.
Yeah, so just be very careful. Make it
Sure.
about your office
Sure.
in general if possible. So
Okay. I kind of touched on the other team certifications. The grants went towards all of our team at the time becoming nationally certified. There is a state requirement today that went into effect July of 2025 that requires our investigators state certified, but we actually, with grants, achieved national certification. We've had some of our investigators move on though, so our staff isn't entirely, but we're still trying. Yeah, and the others we've touched on, we've added the first chaplain. We are in the process of building out a support system for them in connection and partnership with the local fire department and law enforcement chaplaincy so that she has some support as well. Again, community outreach, we're attending those career fairs and we have the ability to offer CWU credit through our internship with the forensic certificate students. So that's every department that's through that: anthropology, psychology, sociology, biology, law and justice majors. That's a pretty big thing. And we're building on the PNWU as well. So our team includes the coroner, a chief deputy coroner. We have 4 active deputy coroner positions, 2 deputy coroner positions that are kind of as needed. We don't currently have an office administrator, but we do have an office assistant that is transitioning to the liaison position. And then we have 1 forensic pathologist traveling. He typically lives in Ballard, but he travels to Eastern Washington and he works for 7 counties total. Interns from CWU, this quarter we had 8 interns, which is the most we've had, and I don't think we'll do more than that. 6 to 8 is generally where we're at, depending on what they're looking for. We offer everything from data entry in the national database that we use to scene investigations to autopsy assistant. We have had pre-med students that are actually helping our pathologist. They're actively opening and closing with his direct supervision in autopsy. So we can offer hands-on experience for some of them. And we do 24/7 on-call coverage. I'm actually on call right now. If something were to happen, I would have to go handle that. So 2024, the most recent figures that we have, is what's completed and ready to publish. 250 cases total, 228 of those were natural deaths. And you can read the rest from there. We already have, we're halfway through this year, and we have already surpassed the 8 organ tissue donations, which is something that the office wanted to increase the partnership there. We, again, in support of the families, if donation is something that they want to do, we want to make that happen. So we're increasing those.
Going back one real quick.
Yeah.
Why 6 months into the year do you not yet have the statistics for 2025? What's the challenge?
I have the statistics. I just don't, we haven't published the 2025 annual report. So I would be talking ahead of that, and I don't want to get ahead of that. That's on my committee's desk to actually publish and put out. And that really is a data entry. We want to make sure that in our program, we have everything that we can entered so that we get, because one little change on one page can actually change it from a natural death to what I would consider suspicious. It's all a language.
And you're not the only one on 24/7, right? Is it the deputies
the
rotate so you
investigators,
can
yeah.
take a vacation or do something or whatnot?
Yes.
Okay.
Yep. We take turns. Yep.
Are you call it every death or just
So
like?
as the CEO, if you will, yes, to answer questions or make those decisions, because by state statute, I deputize or appoint the investigators to do what I would want them to do. So we do have the investigators on, and we have a chief deputy coroner. We do have our SOPs, and we do train. Anything can happen. And our investigators are part-time. They work 8 to 5 Monday to Friday at another job, or they attend school full-time. So in their training, there is no way that they can see every type of death that might happen. I mean, we have an airplane crash once every couple of years, right? Or we have, really knock on wood, the infant fatality once every, and we're past due. It's typically once every 3 years, and we're 5 years now. So we don't see everything all the time. And so yes, my chief deputy and myself are on call pretty much all the time, one of us, just to answer those questions that our investigators may have.
And your office touches every death in the county?
It does not. It's something that I started working with the state Department of Health. I was just in a conference yesterday. So one of the things that we are trying to do with hospice, with KVH hospice, hospice deaths are not my jurisdiction. But typically in the past, Nick wanted those phone calls. And I think that was kind of a throwback to when hospice first came into the county many, many years ago. It was a private organization. They didn't even necessarily have skilled nursing staff that were going out to the homes. So the prosecutor who was acting coroner at the time really wanted oversight for those. And when Nick was elected, it just kind of followed through with that. But that's 50% of the calls we're taking are hospice deaths, and those are not my jurisdiction to begin with. I do need to make sure that we don't miss something. So I have been in contact with Dr. Stone, and she and I both agreed that it would probably be a good use of resources and a huge benefit for the family that the hospice nurse is not having to call me in the middle of standing right next to or in front of the family and answering questions like, who's the decedent, what did they do for a living, which are all demographic questions that we need, the statistics we need for the death certificate. So we need those answered. But not in that moment. That isn't good for the family. So we can do better, and we're working on doing better. So, you know, part of that is kind of, we're going to do a medical review, if you will, of all death certificates for Kittitas County, which also will align us with other coroner and medical examiners offices in the state where they're already doing that. So that you won't have that interruption to the family, but we'll still have the ability to catch it on the end if something doesn't look right. And the way I was trained by Nick is a medical professional. You know why you're signing and certifying death. So I will see that, but I won't change that. I may call with a question if there's all indicated anywhere in the etiology, just to make sure that it wasn't within the last year. The state statute says within the last year, that would be my jurisdiction. Doesn't necessarily mean I'm going to change anything, but it may mean I'm going to pick up the phone and I have some questions for the family. So, did that? answer?
Yes, thank you.
Okay. All right, so some of the challenges we face are some of the same things that I think you face here as well. I mean, you don't have a morgue here at the hospital, and lots of hospitals do. They at least have a cooling room or storage for that. We don't have a morgue for the county. So I think that's something that we can talk about. I do have, the office has a feasibility study where we are looking at partnering with the health department. As you know, it's been very publicly put out there by the commissioners. Our office at the Morris Sorensen building has aged out. That building is no longer, they can't do anything with the boiler. They can't do anything there. So we've been actively looking for funding. However, as a coroner ME office, if there is no federal funding, we are in between law enforcement. We're in between the health department, and there is no specific funding for us. Our office went out and found grants for the three things that we could, and that was the accreditation and the equipment that we have available, but there's nothing for facilities. There's no infrastructure available for us. And it all boils down to infrastructure, right? You guys are probably in a lot of the same boat. So again, why that would matter for you guys is just improving what we can do in partnership with you. And I think we've kind of already gone over all of this, how it helps. I've printed out a few handouts and I can always get more if you guys need, but do you have any questions on anything? Okay. Thank you.
Thank you, appreciate it, yeah. All right, up next, we've got materials management. Bonnie.
Hello,
Hi there.
I'm Bonnie Vidon, and I'm the Director of Purchasing at the Kittitas Valley Healthcare. And pictured is my materials management team. And I came here to tell you a little bit about who we are and what we do. So who we are materials management. We support purchasing, inventory management, and supply distribution across KVH. We have a director, 2 buyers, and 3 techs and a per diem. Here's a few more things that we do. We run a value analysis committee. We do capital purchasing and service line implementation. And then I thought I would share a couple of numbers with you guys. So the first one, the materials management techs have processed about 7,818 requisitions in a 30-day period. So that's them picking, scanning, and replenishing the departments. And then the buyers have processed around 4,860 purchase orders, which is a lot because some of those are 150 lines a piece. So that's them sourcing them, making sure they're connected to contracts and following them all the way out the door and back in. We have a 98% distributor fill rate. That actually has improved from 2025. We were sitting around 93. So that's the buyers working really hard to make sure that all of our usage is correct at our distributors so that when they place an order, we get 98% of it filled back. And in 2025, we switched our GPO, which is our group purchasing organization. We switched the person who manages our contracts, and we improved our contract compliance from 82% to 97%. So we have about 3% left that is either specialty items or we're going to put it through our value analysis committee to see if we can make a switch if it's clinically acceptable. And then our Price integrity has gone up from 83.7% to 94.1%, and that means our PO has the right price on it when it goes out the door, which prevents invoice discrepancies.
Is that what Cassandra was kind of showing me on her computer?
Yeah.
Checking the contract with the price and
Yeah, so John got to tour our department and kind of see the work from start to finish. So that was really neat to have you there and get to highlight, not
very
everybody
enlightening.
thinks about all the work that goes into it, just how much they touch. And you think, oh, they send purchase orders, but it's the amount of work that goes into that is. And then we have, since 2025, $3.2 million in documented financial savings. And in 2025, we had about $2 million. And some of the big wins up there were we found a really aggressive implant agreement, which then gets passed on to our patients. So that was a huge win. And then we had a lot of capital contract negotiations through our expansion.
Can you tell me, in a nutshell, like what does Gloves Stand organization look like? Are we talking about nitrile gloves?
Yeah, so yeah, our exam gloves. So we bought Medline gloves before, but when we moved over to our new GPO, they actually supported the Medline brand. And so without having to do a huge glove conversion, we like off the bat got like $81,000 in sales. So it's nice when you don't have to clinically switch things like gloves, because as you can imagine, everybody has an opinion on gloves and things like that. So we try to just do the huge wins where it's like for like, and then we take this that's not like for like through our value analysis committee. And then Q1 and Q2, we had $1.2 million in financial savings, and the majority of that was all through our GPO optimization. So that's been a huge focus for our team, is just making sure that we're analyzing everything we purchase and that it's connected to contract. And then if it's not, then we work with the clinical teams to see, can we switch, or can maybe we go after like a local agreement that's not with our GPO, but direct with the vendor. And this year we really focused on supply chain resilience. COVID had taught us a lot. So we took those learning lessons and we partnered and got a secondary distributor. So that's been super helpful. If Medline doesn't have something, then we can go ahead and partner with our secondary distributor. We implemented an IV fluids reserve program. We have about 4 pallets sitting in a warehouse that the vendor is monitoring and rotating stock for us. And it's there when we need it. We just pay a pallet fee on it and we can access that at any time. So the situation with Baxter and the natural disaster was enough to make us want to try to do something different. So we were excited when our GPO had offered this to us.
And that was the second time that happened, right?
Yeah. Yeah. The first time, was like 10 years ago with the Puerto Rico hurricane. So, yeah. So we all feel a lot better having our IV fluids on reserve, that we know we can access at any time. And then we looked at our top 100 critical items and we built substitutions for them and secondary vendors. So we took all of the critical things and are able to just, one's on back order, we can toggle between others and we know they're clinically acceptable and get them back in the door. And we worked on inventory optimization. So we implemented first in, first out rotation. So we have a policy now on how we're constantly turning our stock to avoid expiration. And we've been reviewing our slow turn inventory and trying to improve our communication across the departments. We built a materials management page where we list our back orders and we send out product change alerts. And we built new vendor packets. Another huge win for the hospital and the community was we partnered with a few different organizations to reduce waste. And Project Cure was one of them. They're an organization that's struggling medical care across the countries. So supplies that are obsolete for us or equipment that we can no longer use, we send that out to Project Cure and they're able to utilize it. And then also we connected with the Yakima Valley Community College, the scrub school and the nursing school, and they're able to take all of our expired supplies, which is nice because we usually don't have anywhere for those to go. And it feels nice knowing that somebody's using them for education. And why it matters, materials management helps ensure supplies are available when needed, costs are controlled, contracts are organized, departments receive timely support, waste is reduced, and patients receive uninterrupted care. And looking ahead, we will continue to optimize our GPO. And we plan to partner with our revenue cycle management team to advance charge capture initiatives and continue to expand our inventory efforts, optimizing our inventory, support new service line growth. We're currently supporting urology and increase standardization opportunities, as well as continue financial stewardship. Any questions?
Some question.
Yes.
Do you guys track wastage? Like, is there a dollar amount that?
Yeah, we do. So Cerner isn't great with all of the reporting, but I did find a report the other day that every time we waste a supply out of the system because it's damaged or it's just not clinically acceptable or it's expired, we're able to run a report at the end of that. And we just ran one for surgery to see and like, oh, this supply in the, last 30 days or up to 6 months, we've wasted it this many times for this many reasons. So we've been tracking that and either paring down on that stuff. So we're trying to monitor all of the waste with that and try to figure out why they're damaging it out or why it's expiring so often. And then we can go back with that data to the clinical teams and say, hey, we've purchased this 2 times in the last year and we've expired it every year. Like, is there something we can do different? And so, yeah, it's nice to have that.
Amount you could share, like.
I don't know the exact dollar amount of the waste, but I could get that information and send it along.
Yeah, it rolls into this too, as its own sub account in the GL for wasting. I think all those were out there. It's surprisingly low. They do great turning over. They'll have little blips where it's like occasionally there'll be a really high cost medication or something that gets wasted for some reason. That would cause a big blip.
Yeah, I
We
think
had like a Remicade that got missed once.
yeah, and I think we had some surgery. I think in the 6-month span I looked, had only wasted like $3,000, and some of that was like a damaged mesh or certain doctor left, and then we had to try to figure out what to do with the supplies that weren't being utilized. So it's nice that sometimes we eat the cost a little bit. We can at least send those to be repurposed.
Can I just say something really quickly here?
Go ahead, Matt.
I just want to say this is one of the reasons why I love these presentations, right? I knew materials management was crucial to the organization, but I didn't know how to explain it. And so I just wanted to thank you for a very thorough presentation. If you wouldn't mind sharing your presentation, your slides with us, I'd appreciate that because it really helps me to understand what you're doing here and the initiatives you have in place. So thank you for your presentation.
Yeah, thank you. Anybody else have any?
I'm impressed by, I know that you have to be a very busy person just with the day-to-day, but to have a plan to address the lessons learned by the materials management, hiccups that happen giant hiccups that happened everywhere with COVID and et cetera. To be able to attack that in a meaningful way and get us set up for success if there is another speed bump down the way on top of everything else you guys do, that's formidable.
Thank you. I have a great team who like believes in everything we do, and so it's very easy to accomplish things when you have such a great team behind you.
So you recently contracted with a group that we can donate supplies to or equipment to as well. So we often have to just throw things away, even say ultrasound machine because of liability and those reasons. And with this agreement, you're able to donate and repurpose to an organization.
Yeah, I think we've sent out 4 shipments so far to the project here. And we just Q1 is when we started that partnership. So that's nice that and some of the expired COVID supplies that they could still utilize, like face shields and things like that.
And Bonnie's on the finance committee, so Bob and I get to overlap with her every month and hear her stories of which company she ground down to squeeze the dollars out of. And we really enjoy and appreciate, obviously, you and your team, that what you do to make things as economical as possible for the stuff we have to, purchase and whatnot. So
Huge aspect.
yeah.
Yeah,
So
thank you guys.
thanks for coming in today. Is there anything else you want to share with us?
I think that's it.
Okay, thank you so much.
Thank you for
Appreciate
having
it.
me.
Yeah,
Can I say something real
Oh, yeah.
quick?
Please.
Sorry, this is this is Amy. I'm the cardiopulmonary director / EPC coordinator, and I have to tell you, I think that Bonnie is very humble. Her team is absolutely amazing. And one thing I would like to add to what she shared is the extraordinary work that her team is doing in helping me get our emergency preparedness trailers up to par. All of the trailers in Region 7, not just KVH, have been, they are expired, the materials that were received in those. And Bonnie, Christy, Cassandra, all of them, Michelle, have all been so helpful. And we're making a plan to really improve the functionality of our trailers and to work at preventing any of those supplies from expiring. And actually, I'm going to be sharing some of the ideas that they have provided with the other hospitals in our region to see about adopting that throughout the region. So thank you, Bonnie, to you and your team.
Thank you, Amy.
Yeah, thank you, Amy, for sharing those thoughts. Appreciate it. Oh, thanks, Bonnie.
Thank you.
All right, so that's it for presentations. We're gonna move on to reports and dashboards. Quality is first. Mandy is not here tonight. If you've read the report and you have any questions, Jason or one of his team might try to answer it, but otherwise, we're gonna just go with the written report if needed. Any questions regarding Mandy's report?
Yeah, so I apologize that, or not apologize, but the nursing leaders aren't here today. So Mandy Olson and Holly Urban, they're away at a conference with all the PCS leadership team. So they're gone yesterday and today, and look forward to the work that they're doing to invest in their leadership. So for nursing, there's no representation, but if you have questions, I'll find the answer.
Well, there's representation.
Yes. Yeah.
So any questions, I'm gonna try to bump on Jason, see if he has an answer. All right. Hearing none, we're gonna move on to HR. Who's handling HR today?
HR is super similar, so excited to note that Janelle Harding is going to be with us on July 6th. Becomes lots of great experience. Looking forward to welcoming her as the new chief of HR. The report's put together by Jen Strader, so just extra kudos to her for filling that gap for, she said, the 5th time to be interim CHRO. She's hoping to be the last for a long time, so kudos to her. We have changed, I worked with her to start changing a little bit the charts to be more similar to the same charts, look and feel of data and trends like in the quality reports. So you can see like the turnover rates, the rolling 12-month turnover rates, working to then get back data to fill those in. So you can see just trending over time and working on that style of analytics for all of our reporting. But it'll take time to move it into that style as we get there, and then get that history too. So we get ideally a few years of history in those.
Very good.
Any questions on those?
Related to human resources.
I have reached out to Leanne Bolding, she's our process improvement coordinator. And she's gonna be starting a project once Janelle is here, probably the end of July, around our whole recruiting, so. And then recruiting from the time a position is approved to how it's getting posted to recruiting tactics and then the onboarding process as well. So looking forward to engaging with Leanne to help us relook at that process.
Excellent. All right, so we will move on to Jeff, Chief Information Officer.
Yeah, so my report starts on page 23. Just updating from my previous report, the only thing to add is we've taken on the role post go live for UKG with Janine leaving and some of the challenges that we've been having with the post UKG. We've kind of taken that on and progressing. And so basically, until Janelle gets here as well, we'll continue that role even after that, just helping to support the system. And so a couple of things we've recently done is understand it was implemented by a third party in Janine mainly. So a lot of us were out of that information. So understanding the information, but also going back now, seeing how the system was originally set up. And also not trying to reinvent the wheel. So we've reached out to other hospitals in the Rural Collaborative. Actually spoke to one this afternoon that have implemented the vendor UKG and is using some of the same functionality that we have been using or we've implemented. And just to compare, what's the differences between how we've set ours up in there and just trying to get more feedback on that. We've also reached out to the vendor themselves, said, hey, we're struggling in a few areas. Can you give us some additional resources and support? So, and they've escalated our status. And so we'll see where that goes as well. So
excellent.
Other than that, any questions?
Questions for Jeff? Do you have the document for you on page 25?
Yeah.
So just help me understand what I'm seeing here from the graph. So number of breaches, if you take 2026, we've got the 103 in the blue, 47 in the green. So what is the blue is cyber attack? What does that indicate? Is that our facility?
No, this is statewide.
Okay,
Yeah.
that's an important detail.
Yeah.
I'm thinking, there's things I'm not hearing about.
Yeah, it's unfortunately it's on the on page 24 at the bottom. Washington.
Oh,
State.
that's fun.
Cyber report.
Thank you.
Not
It's all the clarity.
Yep.
But can you help me, the green, which is unauthorized, so it's not a subset. So cyber attack is one incident, unauthorized access. So it's not malicious necessarily. It's somebody getting into something they shouldn't be allowed to get into.
Yeah,
Okay, and again, this is all state, it's not ours.
it's all state,
Okay, thank you.
but it's all representing healthcare.
Yeah, you can see, like you said, the AI is really becoming a greater issue, it sounds like.
Yep.
Jeff, can we, oh, sorry.
Yeah, go ahead.
Can we back up to 23, the current active project in the lab for Insight Interface transition? Is that, take a while to do that, or is that almost?
Yeah, that's taken a long time, to say the least. And so, yeah, LabCorp just Insight. And so they are transitioning all of their work, as a company does, but just trying to get now the new interface up with LabCorp has taken a bit. And in that transition, there was some Oracle staff changes and Insight staff changes. And so that has just prolonged this project. I think it should be ending fairly soon in the next couple of months.
So is that Cerner?
Yeah.
Is that Cerner's issue to Insight, or is it our issue with Cerner not having cooperated enough with Insight to? Or
I sit on those, in on those meetings.
In the meetings.
It is, right now, it's a billing, making sure we figure out billing pathways appropriately. We bill the pathology, follows a different process than a regular lab procedure. So it's making sure that we've got the billing correctly for the tests that could possibly be done, be set up for billing and be set up to interface and then be ordered on server. So it is taking a little bit longer. And then we also changed formatting for pap smears. LabCorp had an update and had a different way to get the results to us than when we first went live with LabCorp in 2017.
Yeah.
So there's all these little pieces
Yeah.
as we work along that will be significant improvements, but
We're just using the old system.
it's kind of a combo of both. Some of our work is going to LabCorp, some of it is still going to Insight. But we are getting reports, it is being monitored. We're just not ready to go full blown LabCorp yet.
And and this is, just trying to get all these other entities we're all kind of trying to work together, right, to get this done. All of the pathology services are all outsourced and stuff, trying to be able to do that.
Is there impact on patients as far as like receiving the bills on time or?
I don't think billing has been a problem. I think we might have had some delayed reporting of results. In December, things accidentally were sent to LabCorp and should have gone to Insight. And then we just kind of lost track of them for about a week or two. So we kept all those up, created new processes. This was originally thought they could have done February. They thought this was completed by February. But as we've worked along, there's been some additions and some challenges.
Okay, thank you.
Thanks.
These are projects too. They're not like a project by choice. It's
Correct.
like,
No.
project
Yeah.
by acquisition, and now
Yeah.
you're doing that.
Yeah.
Today, so, and it came to us as just a letter from LabCorp, FYI, this was
Yeah.
purchased,
Yeah.
like, whoa.
We
That's
brought
gonna
out
be big.
Insight, we're gonna change all your systems.
So, and it's constant. That was also similarly with my time getting bought out and changes there with that.
Yes,
system
by similar,
sunsetting.
yep.
Any more questions for Jeff? Thank you.
Thank you. Yeah.
So Chief Nursing is next. Holly, she's also.
Hi. So could you tell, on the incident response plan and exercise, that all went smoothly?
Yeah,
Yeah.
yeah, that was.
Is it me that I hear you or?
You're good. Okay. So no, did we learn anything? We've just like, okay, we.
It's mainly practice, right? And so we create an incident that potentially could happen. And then we step through the process. But we create what's called a playbook for that instance. So if it ever happens, so we can pull out that playbook, and this is the sequence of things that we would do. It's an annual exercise for us to kind of get some exercise and get some, testing done.
Very good.
All right, so now we are done. Thank you, Jeff.
Yeah.
So we're on to Holly, Chief Nursing. She is also away at this conference. So Jason, is there anything you want?
Only thing I'd call out is June 2nd and 3rd, we had DNV come by. That's one of the unannounced surveyors that refreshes our annual accreditation through DNV. Completed that survey, and we have, I think yesterday, we submitted all of our plans of correction and stuff for that. So everything's going very smooth, positive, and well through that survey.
Because they give us a fairly window to give a response, and then when do we hear back from them if they're satisfied, or is it
They
just the next
submitted
survey?
yesterday. I think it's like 10 days or something. Okay, respond. Yeah. To satisfy all those, but when next time they check everything that was indicated as a opportunity last time, they close those out and then they look for new things.
Anything else from her report you'd like to highlight?
So I need to highlight, but you got questions, I'll take them.
Any questions? All right, hearing none, I think Holly's off the hook there. So we'll go to Chief Operating Officer Stacy.
Yeah, so a little bit about urology. Dr. Chavla did 3 days here in June. Very productive. He didn't see patients, but he spent a lot of time with surgery, different clinics, quality. He made the rounds pretty much everywhere. Spent some time in the clinic space, getting familiar and kind of getting tips on, okay, this is where I think the bed would go. This is where I need this equipment. So he will see his first patients the week of July 16th. We are getting referrals, so we're really happy about that. And we're pretty sure we've been busy. We'll have an APC, hopefully she accredited yet, signed. We're still working on it, but we've got a tentative start date in August per diem. And then full-time in September to support urology with the full-time.
August 18th.
So urology is going strong. And then similar to the hospital, the laboratory had their inspection. 8 findings out of 797 elements of performance. So that's like a 90% success rate. And on Monday, we were reviewing our process improvement with Katie for that. And Katie's taking the lead.
Addressing those 8.
Addressing those 8 things.
Sure.
I can answer any questions.
I have a quick question.
Go ahead, Matt.
So could you say a little more about urology, and especially like how that works with having Dr. Chala here 1 week a month and then the full-time APC? Is the idea that the APC can handle most of the stuff? And then
Yes.
we will, okay. Yeah, if you could say a little more about how that works, please.
So a little bit more about that. We are actually going out with a partnership with Virtue Care. So Virtue Care is going to take our APC to Tennessee and train her. So she'll get full urology training, come back, and then Virtue Care will also supply us with another surgeon 1 to 2 Fridays a month to just come in and do surgery. And then they supply the telehealth support for that APC. So what we'll do probably the first couple of weeks is build in time in her schedule so she can sit down and either review cases before they meet or review cases after she's seen the patient. So they'll provide telehealth support to her full time while she's here.
That's great. I mean, I think it's nice to emphasize over the course of, I mean, this board's time on the board, we've added a lot of new service lines, all in an effort to support access and making it so we can keep care local. And so I think it's good to emphasize having urology here, which I think it's been something we've wanted for a while, but adding another thing to that list of local services, I think it's just amazing.
Local services, and I can say we've definitely kept Bonnie busy between clinic needs and surgical needs to support that program is pretty impressive.
Yeah, I'm excited. Thank you.
Like she said, what I like about this one is some of the programs that we've started in the past, we'll just use vascular, for example, we'll recruit one provider and we have that really single source of risk in a program. We'll spend hundreds of thousands to even millions of dollars in equipment, support staff, bring that around. And it's really based around one provider. With this program, we're starting it out the gate with really 5 contracted or 5 providers that are privileged to provide services here, with 1 being employed or 2 being employed, Dr. Chavla, a surgeon, and Mary Lyons, a PA, and then having the 3 Virtue Care privileged providers to help provide support to that APC as well. So see this as a much more robust model for rural critical access areas versus all eggs in one basket on one potentially single point of failure. So excited to see this and see it as a very sustainable and resilient program.
Any other questions for Stacy? Anything else you'd like to share?
We'll be finally offering some speech therapies in Ellensburg. So we hired a part-time who will do some work in Cle Elum and in Ellensburg. So it's been a long time since we've had speech therapy in town.
So that's related to Rehab Visions on that contract before we could not employ a speech therapist in Ellensburg. It had to go through Rehab Visions and they were unable to recruit and retain. So that's awesome that we've got one.
We've got one part-time. Yeah.
And we're still, I think, recruiting for more coverage, but
More coverage and more PTs, a little bit of everything still.
One step at a time.
Yeah.
but they're a tough recruit, like all positions.
Excellent. All right. Well, thank you, Stacy. Moving on to medical staff. First up, FEMA staff, Dr. Hoppy.
Yeah.
Oh, you are there. Do you just say iPhone?
Yes.
And say Dr. Hoppy.
Yeah,
So
I'm
go
just
ahead.
I'm quiet. Can you guys hear me? Yeah. Okay. My report is on page 36. And I think it starts there. We had some reappointments and some initial appointments on the credentialing files. And I'm happy to report two other things. One, we expanded the DOPs, or delineation of privileges, for general surgery to be a little bit more broad. And Dr. Penoyer really kind of, took charge of that. So he did a great job on that. And then lastly, we created EEG privileges, which is basically privileges for the ER to use when they consult neurology and they're looking to evaluate brain waveforms in patients to determine whether or not they have a seizure or not. So, so we created those. So we have those. And then lastly, I'm going to report that we are very close to the bylaws being done. Actually, the bylaws are now in the hands of the lawyer, which are approving them and just editing any changes to be made on the bylaws. So we're really, really close to bringing that back to the MEC for approval, and then it'll come to the board for final approval. So happy to report on that.
Excellent. Thank you.
That's been a lot of work,
Yeah.
a lot of work.
Yeah, it's been
All
a
right,
lot
so-
of work, and I really I credit my partners, Dr. Beard and Dr. Thomas, and I mean everyone for really pitching in on the bylaws. So we're really there. We're at the finish line. I'm super excited about that. So yeah.
Yeah, that'll be a good day when those are all done. So we have credential files in front of you. If you've had a chance to review those, I'll entertain a motion to approve them if and when ready.
So
I'll move to approve
By Bob?
appointments. I can second. Yeah.
Yeah, Matt will second. Bob did the first motion. So we have a first and a second. Any further discussion? All in favor, say aye.
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 I too will vote aye. That motion passes. Next up, we have the delineation of privileges for general surgery, which you have the draft in front of you that was worked on in the MEC and the Dr. Hoppy put before you. I'll entertain a motion when ready.
Move to approve.
Motion by Erica,
Second.
second by Bob. Any further discussion? All in favor, say aye.
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 I too will vote aye. That motion passes. Next, we have delineation of privileges for the EEG interpretations. You also have that in front of you, and we'll entertain a motion when ready.
I'll move to pass it.
Okay, thank you, sir.
Second.
Okay, Jerry and Erica, any further discussion? All in favor, say aye.
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 I too will vote aye. Says aye, so that motion passes. Anything else for us tonight, Dr. Hoppy?
No, I don't think so. Any questions for me?
Any question? All right, thank you for giving us that information tonight. Have a good night.
Yep, thank you.
We are moving on to Chief Medical Officer, Dr. Thomas.
Thank you very much. My report begins on page 40. I have no updates to the report, but I do want to commend Jenna Carlson and the Medical Staff Services Office for their excellent work helping to collaborate with the DMV creditors who put them to the task and asked for a great deal of reporting. And as you are already aware, they're currently underway in the process of adopting the OPPE quality appraisal process. And that is an ongoing and continued project that will continue into next.
Any questions for Dr. Thomas? I was just going to ask, you have a note exploring some existing hospital and clinic services. That's under Jonica's domain. Just so are you looking at it from like demand, what patients need, what we're capable of doing safely, that sort of approach? What are you doing when you say a statement like that?
I could answer yes, regardless of which example you gave.
Yes.
So certainly service line expansion is sort of a broad category of Jonica's responsibility. Technology adoption is another category that Jonica is working very closely with the IS department in order to facilitate. And there are a number of projects which both incorporate new expansion of capabilities within service lines that we already have, as well as the new service lines that that are currently under development.
Excellent. Any other questions? Thank you.
Thank you.
All right, so we are moving on to Chief Financial Officer, Jennifer.
Good evening. My report starts on page 43. Just to add a little bit to my words there on partnerships and collaboration, the WISHA has actually signed the contract for our HTP funding. And we have to go through the process of applying for, but we are eligible for $723,000 of those funds. Quite sure what we'll ask for yet. And then the next page, kind of wanted to just say kudos to our revenue cycle team. They had a really great day of collections today at $1.9 million. And that's, I think, a record. So
I think so.
that was a pretty good day for them. Capital investments, we'll come back to the analyzer. I think Stacy's gonna help us with that when we're done here. And then just a couple little capital updates with Radio Hill. It's well underway. Demolition is almost complete. Electricity demolition is ongoing. They've actually started framing and are on track to not say they're going to be done early, but they think they're going to be done a little early. But as soon as you say that, it's just like DED when you say it's not busy. So the final cleaning is targeted for the first week of November there at Radio Hill. So that's exciting. Questions about my words, and then I'll go to the numbers.
So, any questions?
Okay. The statistics, just wanted to point out a few things. Really busy on the inpatient side this last month and kind of steady for year to date. Surgery is still down quite a bit, 12.3% gastro. So scopes year to date, last month was pretty slow, really slow, I should say. PR busy this month and still down from budget year to date and also down from last year, year over year, a little bit. Rehab, we're talking about rehab all the time and they are suffering, and this all will bleed into the financials when we get there. 29.5% down on rehab visits. And then observation days, a lot about observation days with Holly, was trying to get a handle on what's happening there. It's affecting our outpatient revenues, but should it be is Holly's question. Should it be? What's really suffering for us is salaries. It's just our vacancies are really hurting us a lot with overtime, double time, rest between shifts, agency staff. It's a lot. So I'll go on to the numbers, I think. Last there are questions about these graphs. I did just want to say on the year over year financials on 46, the annualized numbers, while we look at annualized numbers closely, they can sometimes be misleading because if you have a really great or really poor month or two in the beginning, it can affect your annualized numbers. I'm still projecting that we get pretty close to budget. On the dashboard, just want to point out, again, going with today's cash deposit, today we are sitting at 163.5 days cash, as opposed to the, what's 150, sorry, 150.2 at the end of the month. Again, just all timing at the end of the month, but I wanted to make sure to have that today for us. Any questions about the dashboard? Collecting what we're going to talk about.
And just calling out the operating income.
Yeah.
We've got a high percentage of the months over the last year where we've been operating negative.
Yep.
And Jennifer and I spent a lot of time chatting about this, and we're, again, digging into things that trigger this to see what we may or may not need to change to try to get a handle on this. Obviously, long term, you don't want to operate in the negative. It's not healthy for the viability of an institution. So we want to get a handle on this, make any changes necessary, and see if that evolves into something more positive. So,
Right. Mostly again, on the salaries, temp labor, benefits follow that. That's really what they're separating.
I think too, like you think like the OB department, that we want to make sure we're letting people know that, we've got staff 24 hours a day with OBs, and that we went through a challenging period a few years ago, and that stigma kind of has got a long tail to it. We got to make sure people know there is, facility here ready to take care of their newborns and whatnot. So just things like that.
That's a great example on even urology startup. You guys approved $650,000 last month. We're paying salaries already for a program that hasn't started seeing patients yet. OB is a great example. Huge cost to salaries, labor, contracted services. We've also, Stacy Botten, since she left that role as well, she was constantly in day or night, 24/7 on call. We used to staff it with 2 nurses at minimum staffing. We now have increased it to 3 to give that director some more life balance as well. So it's a intentional higher cost. We're doing similar areas to that, like in ER as well. It's 2 nurses at night, but we're going to go to 3. So there is some intentional increase in this as well. It kind of double hurts when our volumes have been pretty flat, if not down.
Well, I think our counties are the tricky size too. If we had probably the OB facility, we could have a county twice the number of people and still give them the service. It's just we're at that bottom end. Still got to staff it 24 hours a day, even if there's fewer people. So we have to do it, but financially it's challenging.
I think I did a study one time for break even on OB, and it's about 1,200 babies a year, and we have 300 babies a year. So
yeah,
that's but necessary.
It's necessary for a community to thrive. So
go on to the statement of revenue and expense. You'll see on the revenue side for the current month, we did beat budget by $620,000, but still leaves us 2.5 million under for year to date. That again reflects those volumes that we saw in outpatient surgery, rehab. So looking into that and observation again. The deductions from revenue, if we keep collecting the way we did today and this month, actually in general, we'll see a little bit of change there on our deductions, and the QAPI work that we're working on our revenue cycle side should show some denial improvement. So I'm looking forward to that, although it might be replaced with financial assistance the way things are going. Speaking of financial assistance, ours is sitting about 3% of gross revenues. And I was looking today, the national average is 1.6. Of course, the national average is at Washington, and in Washington, we have very liberal rules around charity care. So I think we'll just keep seeing that go up.
The reason Jennifer says we anticipate seeing that go up is the HR1 bill and the primarily what requirements around Medicaid. That population all basically qualifies for charity care as well. So if they don't stay insured under Medicaid, it will all fall to charity care. So it'll take more effort on the patient's part to stay enrolled. We are working to pivot and educate our people how we can help people maintain enrollment. We talking about how we can be proactive to reach the population to let them know we're here to help maintain enrollment. Because another thing with that is somebody can come into the ER uninsured. We help them get enrolled in Medicaid. Currently, Medicaid will back pay for 90 days to that when care. That'll change to 30 or 60 days. That's going to be really tightening up. And then that initial encounter will be fall under the charity care. What do you got?
With the state, I mean, they have to renew every 6 months.
Yeah.
So they're not wanting people to re-enroll. They're wanting people to come to the hospital, just have them write it off.
Seek the service. We'll help them get enrolled. Typical enrollment takes more than 60 days. So that first service will fall off. We won't get paid for it. It'll go to charity care. They'll then be insured for 6 months because we help them enroll. And then if it's 6 months and one day they come back to emergency or wherever it is, we start the cycle over. So yeah, a lot of hospitals are extremely worried about this. At a WSHA conference last week, that was the parent topic of hands just being tied, just really not looking forward to next year in the bad ages.
Tell people.
Yep.
Okay, so our total operating revenue for the month was $58,000 more than budget. But still sitting 3.2 million under budget for year to date. You'll see as we move down to expenses, what I've been talking about, the salaries, the temp labor, the benefits are all over budget. But one thing I like is UKG. I may be the only one in the whole hospital that likes UKG, but I really am enjoying the reporting that I'm getting out of that and the information that I'm getting as far as, you know, all the things, the overtime, being able to calculate how much agency staff we have. So I think that we can help the managers to identify those areas of opportunities and try to get back to budget on that. Otherwise, we are sitting at an operating loss of 344,000, but a net income of 362 and year-to-date net income of 2.5 million. Are there questions about that? Then we have the balance sheet that doesn't change too much, but you will notice that cash and cash equivalents are up for the month. We like to see that. And that's about all I have to say about that, unless there are questions.
I was going to just remind people, we have a bond coming due next year.
Yes.
That we need to, you know, begin discussing and planning for. We do
Yes,
that
we
over the next several months, talking about the strategy for that.
Plan is maybe to refinance, but we have those investments
Yeah.
just in case. So we have options, which is nice. Options are nice. And then in cash flow, just really another way to state the balance sheet, you know, where is the money going, as related to our net income. So you show net income of 2.5 million, but where does all the money go? Total change in cash was a little over $1 million from year to date. So we have spent about a little over $1 million. What's about that one? And then we move on to accounts receivable a little bit. Talking about the over 90 days for accounts receivable, ours is sitting at 28% currently. And I always think of 15% as good, but I was again looking at some national averages today, and the rolling top percentages is 22.4%. So far off the mark there, although we're still stretch and aim for 15%. The top decile is 16.1% of that. So self-pay is 24% of our total AR, and I really think that that's their next project. Really look at those self-pay accounts, get them on payment plans for credit, care credit, it's a credit card that gives them free interest for, I think it's 6 months.
KVH actually pays the financing cost for, I think, the first 6 months, and then is how it works. There's a fee that we
Oh, I
pay
know.
on it, and then, yeah.
It's very underutilized. but
It's
I'm
very
trying to push it.
underutilized, yeah.
Trying to push it. Maybe because just really come. And then there's the investments, same as always. We did have this one mature 5/31. I reinvested that this afternoon,
We're ready to agenda up at the end.
3.96.
And how many,
I wanted it to be over for.
I know, that's, what was the term? How long?
It matures, oh my gosh, I would not know.
It's not a big deal. It'll be on the next chart.
30.
Potentially a 4-year one or something.
We're in the middle. We have some coming and then some later, and we kind of planned it in the middle, but I'm sorry.
Sorry.
When get replaced, which one,
What's that?
the one that get replaced?
The one-
Matured out, then
Yeah, which one, what?
was the interest rate on the one that are?
4.4, it looks like.
I think it was last month, the month before, we cycled out all of those really low, like COVID era ones. It was like 0.4%. So those are officially now all gone, and we're in that 3.5% to 4% range for the time being.
So that's all I have there, unless there are questions, and we can go on to the hematology analyzer
Okay,
request.
on to that.
I think it's been in your packet. We weren't able to recommend from the finance committee for approval tonight, because I don't have the expertise that I needed to have on hematology analyzers, so that Stacy would come and answer your question.
Does she know that? She does now.
I knew that.
She
I
knew
knew
it
that.
already.
They had some specific questions, and Rhonda Holden is also involved too. So the first question that was asked is this redundancy or primary? This is a redundancy analyzer. How often will it be used? How often does the primary go down, and what is the likelihood? Katie said that the current primary instrument has been exceptionally reliable, but it is nearing its 7-year life expectancy. The biggest concern with it has a single point of failure. It is a 1 CPU and 2 analyzers. So if the CPU goes down, everything is down on it. So a redundant analyzer, you can't just let it sit there and never use it. So she said it would be used daily for small amounts, quality control, run a few samples through, because you've got to keep it up and running so it's ready to go when you need it. And then what happens if we don't have it when the primary instrument goes down? If it goes down, CBC's pretty much coming to a standstill. We can run a hemoglobin on our blood gas analyzer, but for red cell counts, white cell counts, platelet counts, everything has to go either to Memorial or to our urgent care in Cleellum. So with our courier, when you call in a stat, they have a 2-hour window to come pick up a stat. If we need to move it right away, we would probably have to send our own staff in their own vehicles to take samples down. So if it happens at night, not a lot of staff around, we'd have to call people in. If it happened during the day, you're still talking a half-an-hour drive for an ER patient to get a
This is
CPC.
if the device goes down.
If the
So it's
device.
not standard procedure, this is backup procedure.
This is backup procedure. This is 100% backup. So.
So
What
it's a
else would you like?
workhorse. If it's does the CDC.
Yes, it is the exact same analyzer that we currently have in the duplicate form right now. So excellent quality. It will correlate well with the existing instrument. It's not like we're going to do a backup and providers will say, oh my gosh, counts seem wrong. Results seem wrong. It is the exact same analyzer. It is just separately standalone.
So then when the primary reaches its end of life, this will give us something to fall back on.
It will give us one to fall back on.
While we
So
renew the.
why,
priority.
if we look at where do we need to go from here? Possible to just purchase a second one and attach it to that? That I don't know. Rhonda, do you know? When the primary hits the 7-year mark?
I don't know if we can. I know at that point we would be looking at having another purchase, so we would have another redundancy built in. Because this is, like Stacy said, one of the primary labs that we order is going to be a CBC for ED patients or hospitalized patients and even outpatients. It's probably our most ordered test. And then if we did lose it and have to utilize either memorial or urgent care, it would take a very long time to get a new instrument brought in and validated and all of the testing complete that we would need to be able to use that machine.
And to get an interface built for it too, on top of it. I've worked in the lab when we've had chemistry analyzers go down and we didn't have tendency, and it's not a pleasant conversation with the ER when I have to tell them, sorry, I have to send your test out to Memorial. We'll get it in 2 hours.
And then another patient comes in and then that one's gone. Right. So it's endless.
It could be endless.
Going back and forth.
This is, oh, go ahead.
This device is separate from that large lab piece of equipment we
Yes,
put in. This is not related to that at all.
No, the large lab piece of equipment is all chemistry. It's a
Okay.
completely different vendor, not tied to that large piece. So it's 2 different types of testing.
Okay. And Jason, you were going to say?
I say this is the last piece of equipment that creates a full redundancy, as it notes there, and then just a full refresh as you guys decided. I think it was 2022 when we started really this real big lab makeover and redundancy effort to up our resiliency game in the lab. As Stacy knows, been there when we have services go down, and at least have duplicate efforts.
And so this capital request is for 114,000, but 50,000 that's being covered by the foundation. So the actual ask from our cash is 64,000 or so.
Yeah, it's technically the board has to approve the full amount. Yeah, 140,000. But
work all the magic
50
behind the
grants coming.
scenes, that's
Yeah.
what it should come out.
Yeah, and just kudos to the foundation. That was part of their pledge last year of, I believe it was $640,000 total that the foundation provided for various equipment. And some of that equipment they bought in full, and some they provided big chunks of cash towards.
Any questions from the board?
Nope. Yeah, I'll make a motion.
Motion from
In
Bob,
that motion, I want to only approve the total amount, but acknowledge the foundation and their desire to help out and the amount of money that they're helping out. So I'll make that motion.
Okay.
Second.
Motion by Bob, second by Erica. Any further discussion?
I have a. Are you not people capable of running a CBC with differential by hand? Have they been trained to do it out? A hematocrit or hemoglobin requires not much more than a centrifuge and simple pipettes. And a CBC is, I mean, a red blood count is a matter of some reagent and some blood and a grid. Are they unable to do your backup for your equipment in that way? Well, what you're sending out. This way your doctor or ER team has immediate feedback. Can they do that? Are they?
They could, but it's like smell is tied to that and time, because they're getting a lot of requests coming through.
I understand that, but
And with the machine, it takes what, 10 minutes for everything. So white blood cells, red blood cells.
it'll take under a half an hour to do CBC with differential by hand.
Yeah.
As a medic in the military, we did it that way. I've done it in small clinics, in small labs, and with great accuracy. So are you people equipped to back up their own equipment?
Stacey, you're welcome to answer if you have a comment on that or.
The staff do not maintain competency. We do not maintain the equipment, and we don't have policies to do that.
And I would add that the time is the issue. The staff, and we are staffed right now, assuming the equipment is available. The staff are doing many, many things during it.
Because they put it in, start a process, and then go do something else, or what she's describing. You're there, probably.
You have one person.
Yeah.
And you do have other things going at the same time.
Yeah.
Because you can certainly be doing just that. It's not you have one person tied up that whole time.
Yeah, and I think that sort of approach is very interesting, and that sort of skill set is important. It's not something we're going to solve right now in this discussion, but knowing that's available, it's something I'm sure Stacey and I will chat about in the future, just to see, is it practical? But the people we're training for the lab, like Dr. Thomas says, are very busy with multiple things at once. And that's just the way the modern day works. Obviously, there's the more you can rely on non-electronic things, or whatever you want to call it, it's nice to have. But first and foremost, I think we're going with what the standard procedure is that's in place that works for the system we've designed. Anything beyond that, we would have to explore. It just, you know.
Looking at putting out a lot of money for a redundancy backup system.
Okay, so we're not here to enter into discussions about this. I appreciate your thought. It was very informative. But we have to run a hospital, and that requires making decisions, and the decisions that are overall best for everybody. So that's very informative, and I'm a curious person. So now behind the scenes, I'll ask some questions about that. I can't do it in this meeting. I can't go down your path in this meeting because it's not appropriate, but I do appreciate you sharing your thoughts. So, all right, so we have a motion and a second, I believe. Is there any further discussion? Have we voted yet?
We have not voted.
Okay. Let's vote. All right, all in favor of approving the capital expenditure for the hematology analyzer? Go ahead and say aye.
Aye.
All right.
Aye.
I too vote aye. Anyone opposed? Okay, that motion passes, and I look forward to hearing that the foundation contributed. Thank you.
Foundation.
Yeah. Jennifer,
Nothing.
any other questions for finance? Okay, hearing none, then we will go on to Jason. Chief Executive Officer report. What do you got?
Thank you. Yeah, so we threw my report on the end, so just kind of round up what everybody else said. A few other things to highlight, like Upper County, we had a very successful foundation event on Saturday. I think it was June 13th. Just thank you for everybody that came, those that contributed, those that came and or didn't come and still contributed, and supporting the mission and vision of the foundation. It was a very successful event, and it was also very great to be in Upper County and show our services to that community, and just educate on the things that we have up there and the things we have to come up there. So we just opened the new PT, OT location up there, which is absolutely beautiful. And now we're on revamping that clinic space so that we can expand our primary care and specialty care services up there. So in the coming months, we'll be bringing before the board some plans for some phased improvements to the rural health clinic up there. That one, since that building is owned by Hospital District 2, there will be some back and forth collaboration on how it's funded, how it's approved. They have to authorize improvements. We make them type of thing. So we'll have some dual board work there to make that happen, but really excited to bring more services. I think they're currently something like 60 or 80 days to their next available appointment for primary care. See, Radio Hill, Jennifer mentioned. Got any other questions on that? Otherwise, me and Jennifer went and walked through it last week. They're doing great, quick work, pretty darn clean too. Over there, so I think we got a good contractor, a few hiccups to start, but they seem to collaborate with us well and make adjustments to not have other hiccups for our services that we rely on to run a hospital. Recruitment retention, I was just gonna note, but I had mentioned earlier, working with our process improvement coordinator starting in July to help some of that process with throughput from job posting to interviews to getting an offer out the door. So looking forward to that work. And a couple other little small wins. This last legislative session, the state created a new law that allowed some protections to the 340B program. for the child site contracted pharmacies. And the next day, the big pharma sued the state, and this last week, the state prevailed. So legislation will hold in place. It's just those singular efforts where pharma is looking to ruin that 340B program that started in the mid-90s. It's been a really big erosion for us and also a contributor to our financial losses. We used to get about $2.5 million from 340B. We're pushing about $400,000 to $500,000 in a year now. So we've taken a big $2 million hit to that over the last year. And that's not unique to KVH, it's across the nation, that program. I was back with Wisha this last week talking, hospitals are even considering just walking away from it. It's so costly, there's so many audits, there's so much work to maintain that trail. And now, since the revenues have decreased by fivefold, at least for us, it's becoming harder to maintain that. There are dead staff that work that program even. Any other questions on my report?
Questions for Jason?
Couple of notes not in the report. I did mention, and Jennifer did too, about just the master site planning. We met with JJCA. They were here at the end of May. They came back in June to really do some more finite work with both the emergency room, different modeling approaches. Dee's been great hosting up in the ER and soliciting staff feedback for what we could do in the emergency room. And then same with Upper County with Cleellum. We spent a day up there with staff and key players to look at different options to move walls around and optimize patient flow to expand their services up there. So looking forward to seeing something coming to fruition with FMC and the ER that we can get on the board in the coming months. And with that, I did want to suggest and consider having a special board meeting, as we typically do each summer, to really do a deep dive on, and this one I would suggest being focused on master site planning. And then at the table, I would suggest having JJCA, our architects, our financing contractors, and possibly Jody Corona, who we've contracted with to support some demographic and population health and market analysis at the table to help the board get to decision making for some long-term decisions we need for our facilities. Biggest decision that I foresee coming probably in the next 6 months or so, or at that table to seek information on it. How much longer do we keep investing in this hospital, or do we start looking at a whole new hospital? And our architects are assessing all of our major equipment to help make some recommendations for those options. One thing we know is this campus is not big enough for our hospital and all of our ambulatory services, but it could be big enough for one or the other as well. And since we've invested heavily in this in the last 6 years, from all new lab, all new cafe, all new surgical services, radiology, materials management, we have a pretty big asset right here too. So it'll be interesting to see how their assessment of the rest of the plant is as we look to make that decision. So it's okay with the board. I'd have Mandy reach out and try to work on scheduling some time. We're not ready yet, but it'll be a few months as architects get that work prepared. And then other thing to note, community relation going to kick off full website rebuild as well. So they're going to be starting that work over the next month.
Any chance I would include an app for phones that does app type things?
Yeah, I don't know. The app for phones probably more like a patient portal. Might be what we're thinking. So website is, markets, community relations, tells about our services. App for getting into the patient portal, there is an app, but it's pretty dated, and IT is working to get that app updated as well. Cerner has pushed that out a little bit. We were hoping this year, but Cerner's doing some new beta testing.
Yeah, they retracted a little bit to add additional AI functions for for patients to interact with as well. And so that's coming out here shortly. We're on the list, we've signed. We're just waiting for them to start to pull.
That's where we see more self-serve functions like self-serve scheduling and such.
Good. Anything else?
Nothing on my report. To add just a couple notes or on the events, we're going to do a ice cream social break for the staff just to really recognize and shout out for one completing the engagement survey, but also all of the surveyors that were with us this last month. So the Joint Commission, DNB, and Department of Health all did their surveys of their various areas, and just want to recognize all the staff for the awesome work that they do to have such awesome results of those surveys. So we'll invite you guys to those. It is now confirmed dates. I believe it's July 15th. It's a Wednesday and a Friday, and July 17th for Upper County. That's the Wednesday and Friday.
Yeah, it sounds good.
That's all that I've got.
All right. Any questions for Jason? I will say about the event up in Upper County, it was, you know, great to see it. It really came together nice. They had a live auctioneer, which was kind of a different mood. And I tell you, guilting people who are bidding on things, you know, and publicly shaming them for being cheap, raised a lot of extra thousands of dollars, I think. So he did a great job of keeping the bids going, making sure you didn't give up too soon and stop looking at your wife. So she's not involved in this. It's you and me right now, things like that. So it was entertaining along with raising some extra funds, which was fun to see. So
Yeah. And shout out to the sponsors of that event. Yeah, that's them all off the top of my head, but we had a lot of great sponsors that donate packages to that event and fund the venue and the meals and all of that. So yeah, wonderful production.
All right, so the end of the CEO report. We're on to education and board reports. I don't have anything down here. Is there anything we need to talk about? Okay, hearing none. We are on to new business, KVH policy discussion. So it came to my attention that a flag was in a public space, a little bit concerning from legal things. So we brought it down until we could meet as a group, figure out what level of jurisdiction this needs to be under. It starts with the general policy. So Jason, anything you or your team can share with us as to what the current policy is, if any exists for this facility?
Yeah, so we scrubbed through our policies and we do currently lack in a very thorough policy for facilities appearances, public facing displays. What we've had is, what we did have was actually just a seasonal decor policy. So we did revamp that and looked at other hospitals and other facilities and what they have.
When you say revamp it since this situation arose, or
we've drafted a new policy that's not finalized yet on that. But it isn't, also just speak to it, it's not uncommon for things to be put up in our hallways, common spaces, and needing to take them down, whether it's somebody posting a flyer for an apartment for rent or witnesses leaving things at counters or waiting areas, or other groups leaving things areas that we do have to commonly remove. So we never did address it through a policy, but we should have, and we'll get that cleaned up here.
Okay. So the board members, this is the first time I've had an opportunity to kind of hear some of your thoughts on what's been going on, and if that leads to any of this further discussion, how you know, do we want to go through this at the board level, hand it off to senior leadership and admin to do what are people's opinions about how the board plays into this situation and the solution that needs to happen?
I do have some thoughts on this. If I might.
Go ahead, Matt.
Yeah, I mean, so as I understand it, the idea was we wanted to, when we found out that this was put up by an individual provider, we wanted to develop a policy about what individuals in the organization could display. When you talked about legal ramifications, I think the idea was that individuals may display things that are objectionable. And if we allowed some and not others, then that would sort of put us in a difficult place around sort of free speech stuff. But if we have a policy in place that kind of restricts what individuals can put up, then that would avoid that sort of legal problem. I have more to say about the specific issue here, but is that the issue? Is that a correct understanding of what the issue is?
Yeah, I think the first level is this something we want to do at the board level, or is this something we want to assign to leadership to come up with?
You mean the policy?
Just a slight note too. When I was made aware of a flag being up, when I'm aware of brochures being left out or painted rocks with select language on them, I do go and remove them, or other people do remove them. And for this instance, I had no idea who put up what, and I never do, and I don't need to. I don't know if it's a staff, I don't know if it's a patient or a not patient that's coming to our building. But what the policy will allow is for administration still to do things as well. So if we choose to do things for Pride, like we chose to involve to sponsor the Pride flag or the Pride Parade, to walk through it, to do t-shirts, to do stickers, those things the administration and the organization sponsors and does, they're still allowed and free in the policy.
I think one of the things we need to make clear is that what happened was, with this individual complaint we got, or concern, or whatever you want to call it, it was not taken down because this person objected to it. It was taken down because it called attention to the fact that it wasn't put up by the organization, and it then prompted us, by us I mean the organization, you guys, to come up with a policy around private expression in public spaces. All right, so one of the things to make clear is that we didn't take it down because the person objected to it. It was taken down because he just called our attention to the facts, and once we found out, the organization, found out that it was put up by one provider, we then figured that we needed to come up with a policy around that sort of thing, right? So one thing to make clear is that it wasn't, although it was precipitated by a pride flag, it was taken down not because it was a pride flag. It was taken down because we wanted to make sure that we had a policy around private expression in public spaces before we sort of allowed such a thing to be put back up. That's how I understand it, right?
Yes.
Okay, so having said that, if we're gonna restrict private expression because we're worried about people putting up things that are objectionable and things like that, I have no problem with that. But I do, as a board member, although I don't, I don't handle operations issues, I will say that my opinion is that the organization should put up, the organization itself should put up more stuff supportive LGBTQ plus community. One of the people during the public comments talked about visual cues that indicate this is a safe space. That seems perfectly appropriate for the organization to do. There's a long history of discrimination against members of the LGBTQ plus community, especially in healthcare. And so having signage like that, having KVH as an organization put up pride flags and things like that would indicate that KVH respects all its patients, including members of the LGBTQ plus community. It would show that we support our LGBTQ plus providers, which is important. We want to support them, and just as a business issue, we want to retain good providers, but also it's the right thing to do. If we indicate to LGBTQ patients that we support and respect them, they'll feel more likely they'll be more likely to confide in their providers if they feel comfortable and respected, and that will get them better care. So it's a quality issue. in addition to just about sort of respect for LGBTQ plus patients. And just to address sort of this idea that it's a political issue, it's not a political issue. Just because some people don't like it doesn't make it a political issue. I mean, they're gay Republicans too. But Major League Baseball, NASCAR, and as somebody else mentioned in public comments, other healthcare organizations do this. And celebrate Pride Month and have larger indications of support for this community throughout the year. So if we're going to restrict that sort of private expression, which I understand the need to do that because we want to restrict objectionable private expression, I think there should be sort of as a second movement in this, an organization as a whole that supports that community and puts up these visual cues that shows that this is a safe space and we respect members of the LGBTQ plus community. So I understand the need to have this policy, but I don't think we should focus entirely on the policy. I think it needs to be a 1-2 thing where we don't just say you can't privately put up a pride flag and then we do nothing to support the LGBTQ plus community. There needs to be some concurrent move by the organization as a whole to support that community. And then if someone complains, we can say, well, pound sand, this is what we support and we're behind it, So anyway, that's my 2 cents, but it's a quality issue. It's a respect issue. Heck, it's an HR issue to support members of the staff and providers who identify as LGBTQ plus. So I think we need to have these 2 things in conjunction. I don't handle operations. I don't oversee Crystal Densley's office or anything like that, but as a board member and as a community member who's supposed to support the community, those are my thoughts. Thank you for letting me ramble.
So go ahead.
Okay. So I'm in community relations. Crystal Densley is my superior. I enforce the policy. The seasonal policy does not dictate what people can and can't do. We kept it pretty general. So when I see something that is not in alignment with our seasonal policy, like a manger at Christmas, we call everything holiday, that's for a reason. That's something I would go monitor. But if you look in all of our clinics and even some of our departments, there's seasonal stuff throughout the year, summer, fall, there's little stickies. We don't monitor those. So I think there's misinformation about what people are allowed to do and what they're not. And that's why this was so egregious, is because we allow, especially when our patients walk by, like the nurse's station, they're allowed to put anything they want in there as long as it's within our policy, like our seasonal policy. So that's why this is an issue, is because you actively saw a pride progress flag and took it down because we don't monitor these things. That's allowed to be there.
Yeah, so that's why there's a need for the policy. And so there has to be a policy place. So I get that entirely. Yeah.
But
the policy, I think, would cover all that. Yeah.
Are you suggesting like a list of, because I think Central does it, they go through like approval process, right, to be able to do stuff on campus. So is that what you're saying? You want a list of organizations that actually, hey, we want to put something on your campus?
No,
a contact person or something like that.
No, I think that the organization itself.
Because the thing we're going to run into is because the last flag issue was the policeman's flag.
Yes, we
took down because.
Well, we didn't take it down. We committed to having it up for 5 years, and then we weren't going to do it any longer. But it was misinterpreted as us doing a blue pride thing. But it was for
the
officer who passed away. But like Snoqualmie Health flies their pride flag with their American flag outside.
Who does?
Snoqualmie Health. So a lot of people are doing way more than we are.
Right, and so this is the idea, like with the support for the fallen police officer. When people complained about that, a couple of people complained about that. Julie said, "This is important. and we're doing it. So like it or not, that's your problem. And
It would
you know,
have
she had an argument for it. And so I like
would
the
have been
idea
nice.
of cave. Yeah, sorry, go ahead.
It would have been nice at that time if it had risen to our awareness, the need for this policy, because then, I mean, this could have been rectified back then. But now is our chance to put it into policy and protect what needs protecting.
Right. But what I'm saying is the policy is not going to address the larger issue of whether people in the LGBTQ plus community feel safe, supported in the organization. So it's good to have a policy. And I think, and I'm all for having a policy that limits sort of private expression in public spaces at the organization. That's fine. But then I think it's incumbent on the organization as a whole to show their support for that community. If we're not going to let individual providers do that, fine. I understand why you wouldn't want to, because we don't want individual providers putting up Confederate flags and things. I get that. But then the organization needs to step up and show its support by giving these visual cues that show people that this is a safe space for members of the LGBTQ community. So I don't have a problem with the policy, but I think if we just focus on the policy. So anyway, I'll stop talking.
And I think I can speak for the operational side. It won't end at the policy. It'll start at the policy. And it gives us the ability to do things such as we don't currently have a policy to participate in the Pride Parade. And as much as I have one complaint of the flag up, I've had multiple of us participating in the Pride Parade. And I can stand by that confidently. And I'm glad that we did it. And I signed off on it, and I'll do it again. And this will give us the ability to lean forward as well. And I appreciate the comments from the community, and we'll be able to adjust our tactic as well. But we were intentional with Pride. We're intentional with the decals. We're intentional with the shirts. We didn't put up anything in buildings. Maybe that was a misstep, or maybe it's a learning opportunity to adjust. And the policy is our learning opportunity to adjust and a starting place.
I want to hold public comment until we get through. This is the board discussion to start, and then we'll reach out as needed. So, yeah, Matt, I agree with you. I think there's two things at play here. One is to just firm up an official policy in general, and then secondly, specifically address this issue. So I think we got to go sequential though. It starts with the policy. So this document that's here, this is a draft, is what you're saying, or so it should have the word draft written on it really clearly. Can you summarize then? It looks like this was done on the 23rd, which is that today?
Oh, 2 days ago.
2 days ago. Can you summarize what this policy states?
Yeah, it just allows the organization to put up things in the popular areas, public areas, and it limits things staff, public community can put up in the public spaces. So it does allow the organization to, it does limit what the public.
And this is a draft that's not been approved, or it's a draft because it's still evolving, what I want to recommend?
Wanted it to come here to hear comment, and because the board wanted to hear it, otherwise we will get it tightened up and finalized in short order.
And this wasn't in the packet though.
No.
And I don't believe it was emailed to me. So this is the first time I've seen it. Did he email it to us at all? Or did I miss it somewhere?
Should have got you. Yeah, I pushed it out 2 days ago.
Oh, yeah.
Yeah, email that Tuesday, everybody.
Okay, very good. That's my fault then. I did not see that email. All right, so I'm assuming everyone else that got the email then has read it. You've heard Matt's thoughts. I'd welcome other thoughts from the board members on the general policy to start, and then secondarily, we'll go to the specific situation.
I'd like to see what University of Washington's hospital says and what maybe Snoqualmie, right? Or
I know there's a few in there, like we have Chelan. Chelan's attached to this.
I did my research. I can send you all the screenshots of what other Washington healthcare.
And you got Mason Health in here. So do you want to summarize real quick the policies of similar institutions?
Yes. Oh. I actually meant like send you something.
No.
Well,
I mean, you can have a set too. I mean, that's...
UW, when I went and looked and did some research, they did not only multiple posts about just pride. They're very open in all of their spaces. I've been a patient there and they always have, you know, things that make all different kinds of people feel welcome. But they did multiple posts, they participated in their local events, and they did many social media posts. And I believe they're ones who did like interviews with their staff too, that they posted out there.
You're talking about social media posts.
Yes.
And you know as well, I'm asking anytime we do an event such as participate in Pride and those do get posted to social media. So you should start seeing more of that stuff on social media as well.
Yeah, I usually post same day, but this year I didn't get to be in the parade. So.
So I'm trying to recall, is this exactly the same policy that we got in our email? Has anything changed between email and this print?
It's the same.
It is the same. I thought I had read something about.
Sure.
I printed his email.
Okay, perfect. I thought I had read something about clothing, personal choice, what people wear on their own clothing. It is not supplied, not saying.
Yeah, like
it's per
badges,
but yes, what somebody might choose to display.
Choose, yeah.
I thought I had seen language about that, but I'm not.
There's also the separate policy governing appearance and dress for workplaces, and that was a policy that was
Is that
updated
maybe what I'm
last
thinking
year.
of?
It's quite possible that is political speech is covered within that policy,
Okay.
the explicit conversation that,
So maybe that's on. That's covered in a different policy and does not need to be covered.
and I think they're both parallel because typically expressions of personal belief will both occupy the person and the physical space that the person operates within.
And so is that allowed?
Well, there are certainly limitations around political speech for employees while they're at the job.
Okay.
There is, I did notice something in the policy that addressed this. I don't know if this is what you were talking about, Erica. But under, I guess this is on page 3. It says, so this is about KVH recognizing healthcare awareness initiatives, cultural observances, things like that. And it says they may distribute organization-sponsored apparel, badges, pins, stickers, ribbons, etc. This struck me as a little odd, but maybe you could correct me. Employees may wear organization-sponsored awareness or campaign items only during the designated campaign period established by community relations. So I mean, I guess I understand, because, you know, like if we're trying to promote, you know, flu shots, you know, it doesn't make sense for them to wear that, you know,
It's also around, KVH has long history with the rodeo. So we do like the rodeo week, and for that 1 week, you can wear rodeo attire. So that's what that was aimed to also.
And Crystal's here. Are you the current author of this document? Do you want to address Matt's question right there, or did Jason just cover it enough?
That's part of it. That line was added just based on a conversation that I was in. Saying that if we do specific health campaigns, then promoting it during that period of time and asking our staff to please, you know, wear those items. Like, for example, in the past, Julie would do like Veterans Day, and we would make shirts that all had American flags, and we would ask our staff to kind of wear that during that period of time. And Pride is absolutely part of that conversation that we had. If we're going to put, you know, make this a health initiative month regarding the queer community, then at that point we would, you know, have whatever items we distribute to the clinic, lanyards, whatever it might be that comes from our office, and encourage our staff to wear those if they feel inclined during that period of time, in particular, like the month of June, but leaving it a little open-ended so that the parameters of whatever that celebration is or whatever awareness campaign it is that we're working on, that we can set those parameters.
Is this also?
I understand.
Like,
sorry, I appreciate that, Crystal.
Yes.
Just a second, Matt.
But
just second. Like Heart Month, February, right?
Yeah, or Breast Cancer Awareness Month, October.
Right.
That's a great example of this.
So to get the big push and the recognition, to be that pop of recognition during that moment of time, not saying that we can't support those causes other times when they, but like if it's part of a campaign specifically, that's why it would be time limited versus.
It reminds me, my husband's a state patrol officer, and they all wear pink badges during the month of October. Every officer wears them, and they can only wear them during that month, and then they have to go until next year. My husband looks forward to it every year. So that's an example.
Which doesn't mean he doesn't care about it the other months. It's just part of that campaign. Okay.
But he can't wear it. Besides in that month. So that's to say whatever rainbow thing is given out by KVH during Pride Month can't be worn in any other besides June.
We've not gotten to that portion of it yet. That's what we're trying to sort out. But
Yeah.
that's a good point to make sure we cover it. But I think.
that's-
we
yeah,
just picked up
that-
some specific
sorry, that's-
examples. Go ahead, Matt.
Now it's your turn.
That's the problem I was trying to address, because the way it's phrased is they will wear those only during the designated campaign period. And I'm trying to sort of anticipate this idea that, July 1st hits, and then if someone's wearing their rainbow, lanyard or something, it's like, get it off, take it right now.
You're
That
correct.
sort of
Is what
strikes
this
me as,
draft
yeah.
is insinuating.
Yeah, so, all right, to be fair to you, since let everybody else talk, go ahead.
I think that, sorry, I am a community member. I think that specifically for the issue of people who have been discriminated against, like the LGBTQ plus community, it is harder to regain the trust of communities that feel that it was taken away from them than to have it year round, right? And so like in the issue of the pride flag, it would make sense that it's up because all the other hospitals have them up, and it's an active representation that we are still KVH is still a trustworthy community member, and to take it down loses the trust of those communities. So I feel like for very specific issues that regard discrimination against communities that have been discriminated against for large amounts of times, it does make sense to leave these things up, because once you take that down, you can't take that action back. And from a public persona of how an organization is viewed, I think continuing that trust is more important, especially in a university town. This is an environment that's supposed to be seen as a little bit more accepting towards all groups of people. And if you decide to say, we are going to police this specific issue, then you're actively losing the trust of the community. So I think that's a really important thing to specifically address, because this issue is nuanced. Thank you.
Thank you. Yeah, so we need to get clarity on the difference between a temporary event and full-time. So it feels like, we have to do a little bit of work to tweak that and make sure that we're not unintentionally saying something we don't mean to say. Board members, I want to just continue with the general discussion here. Terry, do you have any thoughts you'd like to share on this topic?
No, I agree with what Matthew said.
Okay. And so we have this document before us. When we're ready to move forward, Jason, are you looking for a motion to actually put this officially in the record, or is this something you guys want to handle at your level?
I think we got the work to do.
No, I don't mean we're gonna do it. I said when we do it.
Yeah.
Are we doing it at the board level or Jason's level?
The board,
That's what he's asking to get an answer.
I think we should use the board level too.
You got two boards. Want to do it? Do you want to do it at the board level?
What is,
It.
what do we have bylaws that govern how this should be handled?
I believe it's technically an operational policy that I absolutely like, amongst other things that we seek revision on, and to work through, probably through Mandy to look at revisions. I think it's a good draft. We can work through it right here. We can take it away and work through draft at the next board, but absolutely open to feedback and adjusting.
So when we get it to where we want it, what happens to it then? Do we do anything, or is it just handled at your?
Then it goes to operations and we operationalize. Yeah.
I'm gonna try this question one more
Can we
time.
vote on it?
Does the board vote on it?
No.
Okay, that's all I need to know.
Yeah.
We're just gonna get it to where everyone is happy, and then your office will do what you usually do with these sort of policy level things.
Absolutely. But the board is welcome to vote on the policy too, but
But not.
I'm not against it. I'm saying it is a policy, just like our apparel policy that we just have.
Yeah. Which I've never
just a
voted
year. So it's a policy, just like a lot of our policies, but Totally welcome if the board would like to.
So I think, I like having a policy. I think this is something that's imperative that we get right. I don't think that happens fast, though. So I'm trying to balance being speedy with getting something meaningful out there as soon as possible, but also not flubbing it up and making things worse. And so I don't know how, with the constraints that we have with OPMA, how Open Public Meetings Act and how we're allowed to engage with each other outside of the public meeting. I don't know how to accomplish this and get it where it needs to be. I mean, just every sentence is easily, a 20-minute discussion. And because it's that important, anybody have any suggestions on how to tackle this in a way that gets this policy where it needs to be in a timely manner?
Well, one option is to put it out in the public sphere for a month, the draft that's here, and then at the next meeting, have actual public comment on the draft and see if anybody is find something that we missed that's really important, get corrected. We do the corrections, and then typically the next meeting after that, you now include those corrections. This is, again, following kind of the template of how city council does the first reading. The second reading gives people an opportunity to take a breather, go look at what the text actually says, confirm that they're happy with it, be able to make suggestions if they're not, have those heard, and possibly implemented if they're agreed to. So you kind of get closer to this finish line where everyone's had a chance to have their point of view heard before the final decision's made. So I think that's, go ahead.
Well, I was just gonna say what John said is 100% what we should be doing. So that's the direction it says. This policy is very important. And what John just said, it's the way I agree with it should be moved.
Look,
So the thing I need to, go ahead, Matt.
I don't want to beat a dead horse here, but the policy is one thing. And yes, we have to get clear about the policy, but the second prong of this, as I mentioned, is the organization showing support for the LGBTQ plus community. What we have right now is because of a policy or the lack of policy or whatever, the pride flag was taken down that was put up by a provider. All right. We can talk about the policy for the next 3 months if you want, but tomorrow the organization could go in and put up a pride flag. We can't, I don't want to hide behind the policy and not address this larger issue. Yes, we have to.
Matt, you're stealing my thunder, because that was the point I was going to make, is we're going to have to separate these two things, and we may have to do them out of the order I'd hope to do tonight, because this is not going to be ready. But it doesn't,
right, thank
we're
you.
certainly going to discuss part 2 momentarily as soon as we develop a plan for this. So again, I don't, Bob, how do you feel about taking some time, however months it takes to go through this?
Yeah, sure.
Hear from the public, put it out there, make sure there's a chance to find anything that comes up short.
Is that there's a possibility, this is Washington State, that hate groups, could also put attention to them. And
that's the next thing, that's the next question I was going to put out there.
Right, because I was looking at a website today where this is kind of interesting. They took all the hospitals in the country, some that targeted which hospitals are ripe to be taken over, but from venture capitals, right? And so throughout the whole country, so you got people actually spending time doing this stuff, wasting time, versus just let people do what they want to do,
Do you think that there's a certain protection instead of individuals putting that out there in the hospital, the organization saying, yes, you know you, yes, you know you, for the hospital to take the action and put things up? That way, it's not the hospital saying that somebody's language matters more than another, which is, I think, the big legal risk. If the organization takes the initiative to display whatever, it might remove some cannon fodder.
Well, what we need is a policy that doesn't expose us to having things put up which are inappropriate and that we can't legally defend.
Right. So if we take down things that anybody puts up and do that equally, and then we put out our own things, I feel like that's separate and different.
Yes, and I'm not disagreeing with what you're saying is I feel it has to be company-wide, hospital-wide. So public spaces are owned by the hospital as a whole. And it needs to be a conscious decision by the hospital to say, we're putting this up and we're taking whatever risk we do when somebody complains they're being discriminating, so something hateful that we obviously won't allow, and we have to go to court. We need to be able to stand and defend that. And that's, I'm just trying to get to that. Because so it is what you're saying. So I think we'll have to stay away from individuals just putting things up randomly that we don't know what they are. We don't know what, but institutionally, we're going to get to Matt's concern here momentarily. It's what we're going to do about this particular situation. But we still have to figure out this underlying thing, and it's not going to happen quick. But we do have to decide, once we allow one group to be represented and we tell some other group they can't because they're offensive, are we ready to go to court for that and expend the money it takes to defend that sort of thing? That's what I just have to get, that we all are in agreement. That's what we're doing. So
Another thought that could help with kind of the speed, because obviously things take 1 month apart each, is the board could elect 2 commissioners to kind of sponsor the policy, help work it with operations, and then we bring it back to the board. And at least 2 of the commissioners have had a lot of time to really redline and go through that and reason through, and then we'd have it before the board.
we can also call a special meeting that is just about going through this policy line by line and offering feedback. I'm open to whatever solution.
Do the liaison, so to speak, that model followed by a special meeting. That way we're not waiting for multiple sessions. But I feel like we could get a lot done with your model and then take it back to everybody.
Yeah, I'm very content to have 2 of the commissioners start the process, go through it, and at some point do a public session such as this, whether special or regular, to go through it now as 5 commissioners. Yeah. Come to an agreement and be ready to implement it at that point. And there have to be moments for public input. So again, everyone feels like they're a chance to be heard.
What would you recommend this one?
So what can we do right now? Back to Matt's question. Like, what can we do right now for this year?
Well, right now, I want to see if we have a strategy that works, and then we'll figure out. So you ask your question again.
I would certainly be willing to be on that policy team of 2. Who would be, if it was me and somebody else, who would we be interfacing with to work on this?
Well, I think I wish we had someone who had a background in ethics.
I don't.
I know.
If only we had a doctor of philosophy and ethics at our disposal to move forward. I would think Matt and Erica would be an appropriate starting, but because again, we're still going to come back to all 5 of us, so we're going to have a chance to all be heard. But yeah, Matt, are you willing to work with Erica to do behind the scenes to get this as far as you can?
Oh, sorry, Matt. I didn't mean to.
Yeah, hey, Bugs. Yeah, I think I can work with Erica with, she's all right. I'll be all right.
When would we be set up to receive public comment on what you're coming up with?
I mean, I don't know. I mean, we already have a draft.
Can it wait till the next official board meeting, or would you get the draft done like a week or so before and we make it available to anybody who wants to come and talk, or have a special meeting? What's your preference?
I mean, Erica, what do you think?
So I would like to first, well, that was my question for Jason, who, now that we've determined likely who it would be, Matt and myself, who we would be working with to get something that we feel is presentation worthy for perhaps public comment or moving forward.
Yeah.
Who else?
She's the
Anybody else
operation
besides
of that.
Crystal?
Would we want
Interface.
we want to be from staff or the public to be able to participate at this level to speed things up? Because what you don't do is do a whole bunch of work on a policy, then you put it out to the public and you realize you missed something really good. And you feel like, okay, we got to start over. So I'm just asking the question that the commissioners have to decide, are they comfortable in basically having a few involved in this discussion? The 2 of you, Crystal, and possibly some other people. What are the thoughts on that?
I agree with it.
So
I
Crystal,
think the 3 of them can come up with something and then go from that. So you got to create a balanced
I want everyone to feel like they're having a chance to be heard, and the later you wait to have them heard, the more work you may have to undo if you're not getting something.
Matt, what are your thoughts about requesting Crystal to help us determine who should be?
Leave it with you guys is what you're saying?
I mean, that's fine. I mean, I have to admit, I mean, the policy, as I understand it, what we're trying to go for is to have something that says, hey, individuals can't be decorating sort of public spaces of the organization. I mean, it seems like that's where we're headed, and that makes sense because we don't want to have to make discrimination between people putting up stuff that we like and support and people who are putting up stuff that's offensive. So I get that. I mean, that's the general thrust of where we're going, and it's really just around the outside that we have to make sure it doesn't capture stuff that we want to leave out or leave out stuff we want to capture. So I get that completely. I think we can do that. It's not that hard, it seems, given that I think we're all on the same page that that's what we want. Right?
And with Crystal being the operational person, Crystal is awesome engaging others that she feels might need to contribute to that conversation too. So she may go meet with people, talk, gain input, and bring that back to the table or invite to the table. I have full faith in Crystal being able to navigate that.
So I feel if we appoint Erica and Matt and Crystal as the core team, let them figure out all the logistics behind the scene to come back with a policy that's been fleshed out, discussed, and people have had a chance to offer their input. Is that, are you feeling that's a solution? And then I think we go at whatever pace we go. You guys will inform us when it's ready for a meeting, either special or regular, to go to the next level of kind of putting the stamp on it in final discussion. So Matt, are you acceptable with that? You'll be on this committee and you guys will figure it out.
Fine with me.
So you guys putting a pride flag up tomorrow?
Yeah, it needs to.
That's the next discussion. Let me go one thing at a time here. Okay, so the three of you will figure that going forward. So we'll put this aside and you guys will just let us know when you're ready to share some of it. It's tomorrow or 3 months from now, however long it takes you to do the work. Okay, that being said, we don't have a policy, but we do have a situation. And so now I would like to address Matt's concern, and you can speak to it if you want, but we took a flag down. I'm, concerned for legal reasons. I need a consensus as to what we're going to do about it 5 minutes after this meeting ends or whatever. So we're going to start with the commissioners. If we need to, we'll reach out and get more input, but I want to start with the commissioners. Tell me your thoughts.
If we're looking at a flag, like the flag out here or the flag at.
Everything is open. I'm not, there's no parameters. We just know we have a situation that came because a flag was put up without a policy in place that could protect us legally. So now we know we're working on a policy, but in the meantime, what do we do tomorrow? What do we do tonight?
Yeah, I wear a flag under the US flag out here.
Outside the building, what about in rapid access?
Well, I'm a hard time figuring out where if it's at the front door, if it's the second door.
It was hanging next to the doorway. I think we're going into the space. It was just a narrow one, I believe, that was just hanging next to the window, between the window and the door.
I don't think we should use.
No,
We should have our flag. She should have to use her flag. So I don't really care.
Erica, your thoughts?
I am not a designer or decorator, but my big concern is that it is displayed. It's the organization who is displaying it versus individuals displaying it, just because of the unintended consequences of individuals.
Do you have any issues if the organization does display such a flag?
Is there a US flag at the medical arts building?
There's no flag.
We don't have a flagpole. We have one in Clallam though, at FMCE.
We get a flagpole. All right, that's another discussion. We'll
Write it down.
So Matt, our dilemma is, what do we do until a policy is in place? What are your thoughts?
I agree. Let's I mean, I'll be home tomorrow. I can hammer it on the door like Luther's 95 Theses if you want. I mean, anything. Like I like the idea. Let's hang it up under the American flag here. Let's find a place for it at the MAC. I mean, I'm all for putting stuff up that would indicate that the organization is behind LGBTQ plus providers and patients, you know, as soon as possible. I like the idea of, I mean, we have some providers who feel very strongly about this. I like the idea of maybe, I know the things we do well are putting committees together, but maybe getting Crystal talking to them about what might be done sort of regularly to address this issue and to have these visual cues, as one of the public commenters talked about, so that we could, so it's not just like Erica said, I mean, I'm not a designer either, but so we could get some input on what might be appropriate going forward. But in the meantime, yeah, let's stick something up there to indicate that the organization is behind this population.
Gary, your thoughts?
Well, what he just talked about, but I really do think we need a public comment on this.
That's underway. That's going to be taken care of. We're talking specifically about how do we show, how do we represent how the organization feels about this particular situation? Do we want to, but without a policy in place, do we want to go ahead and move forward and demonstrate through, you know, the hanging of flags that represent this? Gary?
Yes.
Okay, good.
Pardon me, John.
I just wanted to.
This is what we do. We do organizational engagement through every department. Our department touches every department in KVH under this umbrella. And we're very good at getting things organizational wide in a very short amount of time. I'm very confident that our office can have something done in all of our clinic spaces by tomorrow morning. My gut is kind of telling me to focus on safe space, inclusion, and all are welcome for care here under that umbrella. And we can get something out to all of our spaces that is respectful, tasteful under that umbrella, and we can get that done by tomorrow.
So my remaining question is still, if somebody comes in and wants to hang something truly offensive, where do we stand legally at this moment?
That's an ideology. We're people.
Excuse me, I'm running this meeting, okay? Just please don't do that. Okay, I'm asking this of the board members and of the CEO. My job is legal protection of this hospital. So please let me have that conversation. What do we do if we get sued?
Yeah, I'm totally not an attorney to speak to that stuff, obviously, but there could be some other groups that want to hang flags too, and we could be back at this table with another group of individuals. We do have past practice that we can lean on. So when we put things up, we do stand behind them. That is past practice, and that does have pretty good bearings for some things as well. Again, I can't speak to the legal risk and level of legal risk in that. So like with the flag, first thing that I knew, we sponsored the Pride Parade, knew we did shirts, knew we did shirts. Awesome. Didn't know we hung a banner, went down to check it out, and there's two things that would happen from that. I'll check to see, did we put it up? And the first call I made was, Crystal, did we put up a flag? If it was, awesome, all for it. If we didn't, then we have to make adjustments. So it would be something that I would put it to our community relations department, just as if they had done it before.
Does anyone know what the city did when they had their issue with, was it painting the road or something like that?
I mean, yeah, they've gone through a few issues. The one that I was referring to is people were calling in on public comment and using incredibly offensive language because they couldn't be stopped. And Rich would try to, pause the thing, and the attorney's like, you can't do that. We'll get sued. You gave everybody else their minutes, you got them their minutes. So the problem is people, they're not even from this community. They're not, so again, I just need to, my job is to protect the hospital financially. And I just want us to know that we might get sued for all the wrong reasons, not somebody who really cares what they're doing. They're seeing an opening where if we don't let them do it, it's discrimination and we have to pay them off. I just want to make sure everybody's ready. And we're weaker without a policy. We'll be stronger with a policy because at least you can put that before the judge and say, here's why we do what we do. Right now, we're saying this group can show, we're standing behind them. This other group comes in that's really offensive. we don't want to put that up. We're not going to put that up.
Wait a
All
minute,
I'm saying-
we're not, yeah,
Go
we're
ahead.
not standing, the organization is saying we are committed to this. All right, some individual can't come in and tell us to hang up a Confederate flag. We say that doesn't stand, that's not the organization's values. We're not going to put it up. If we're not letting anyone put up their private stuff, it just because someone says they want it up, they don't get it up.
But they can file discrimination that they want to be represented also. I'm not saying it's a good argument or they'll win it. But what they're hoping is the cost of litigation is such that they get paid off. Rather than going to court.
Yeah, I'm not gonna
I just
cower
put it out
behind
there.
you know,
All the other
yeah.
commissioners.
I mean,
can disagree
UW
with me,
does
but
it.
I hate the delay.
So
I need you here in person.
when we lived in Mount Vernon, my daughter came home from school. She was in probably like sixth, seventh grade with the flyer from the Satanic Club for an after-school program. Parents were outraged, reached out to the school district and were told, well, because we had sent out flyers like the Christian Bible camps or after-school programs send out flyers, we had to allow this club to send out flyers. The way they handled it, the flyers got sent out and they just put a statement on their webpage that it was how they handled it. We had to allow it because we allowed other people to do it. I think I had the opportunity to speak with Campbell after this incident. We agreed it is sad that we live in an environment we even have to have a conversation about this. One of the things Campbell was very passionate about, though, is moving forward and providing education for KVH, but also making sure that the community feels safe here and not just during June, but all the time. And I mean, she went out and she purchased pride pins. It's something as simple. We can work with Crystal and let people wear pride pins all the time. Yes, we can do the flag, but it is really more about shifting how we approach this. I get the concerns about legal, and the answer can be like, you know what? We're not going to fly that flag, the Confederate flag. We don't support it as an organization, and we're willing to take that risk. I don't know if that's what you wanted to hear.
No. Go ahead, Matt, over.
I mean, UW is doing it. Major League Baseball did it. NASCAR did it. I mean, it's not a political claim. You know, it's not a religious claim. Some people may be offended by it, but some people might be offended by C-sections. Who the hell knows? I mean, we stand behind certain principles. These are not religious principles. They're not political principles. It's about respecting members of a certain community. It's not about disrespecting anyone. I don't see any legal challenge. If they're going to challenge someone, they can challenge UW or you know, NASCAR or Major League Baseball. I think all these organizations have realized that it is not a political stand on par, and it's not a religious stand on par with sort of Christians and Satanists.
I'm gonna say over. Thank you. Yeah, so I'm in full agreement with you. I just want people to be aware there is a legal risk, and that's okay. We take legal risks all the time. I just don't want to go in blind. So as long as we all agree, and that we will not see, they put out that flyer. I would not let them fly a flag that's not representative of our ideals if they want to take us to court. So that's the one thing I'm just saying is that's the stand I'm going to take. If somebody wants to do something offensive, I'm going to say no, even if it means we got to get lawyers involved and it might cost us. But I think it's, you know, we're going to only hang things that represent who we are as a community. So
an idea of another
please
that could potentially affect just a little bit of that is we do have a draft policy. It can be the policy that's as of today, which allows us a policy of what we want, and we can update a policy every single day of the year if we want to. So operations can say at the end of today that this is our policy. We can do what we want.
So even though this is a public hospital, it can't have somebody put something illegal flag up here. That's what I'm thinking about. If they're putting some type of illegal flag on here, they can be taken down immediately because it would be the wrong thing to do, and we could even sue them for putting it up.
Thank you, Terry. I'm fine. But what was the sentence we wanted to change in here?
I've highlighted it. It's on the last page and it starts with employees may wear. We can even just remove that until the committee that meets has.
But hang on, I'm not seeing it yet. So I'm on the last page, which has your,
It's above the departmental consistency. It's this paragraph down. It starts with employees may wear. Do I have an,
I'm on page 4. Are you on page?
oh, pardon me, I have a different draft because I wasn't. What?
Now, we were told this is the same draft that Jason emailed everybody. Do you have one that's later than that?
Is this, it's above departmental it's right here. Employees, but it just didn't get an extra space. So it's under organizational awareness campaigns and staff participation.
Oh, okay.
It's the third paragraph, starts employees may wear.
Okay.
It's that complete sentence. It ends with community relations.
Because it's got the period established by community relations.
Yep.
So
That's
we're gonna strike that whole sentence for right now. Is that
Right.
correct? And you guys can tweak it as needed. And your document that you have in your hand is the same text I have in this. Nothing's changed since Jason emailed it.
No, what this is that I ended up combining this policy with the seasonal decoration policy, that it was all under that same umbrella of what's public facing. And that's the thing is I just don't have that printed version.
Are you asking if what she's holding is what you're looking
The
at?
text word for word
Word
is
for
the
word is the
same
same.
for this part of the policy.
Word
Thank
for
you.
word.
Okay, good.
So are you suggesting that this is kind of a lifeboat policy? I don't know if that's a great terminology, but to get us,
Bridge.
protect us for a little while until we have something
Correct.
that we agree is a better policy.
Yep. And like Jason said, we can adjust this every day of the week.
Yes,
true.
yeah. So I think
Not a bad point.
what I would do at this point, if we strike that sentence, that as a board, we vote on it right now, that we support this policy and are handing it to your department, or do you want us not to vote on?
I don't think it makes a difference. But
I would pitch that you vote to direct the chief executive officer to draft a policy.
But not the specifics.
Does that mean?
I don't know.
Oh. Okay. So direct them to do the policy, but don't do the policy.
That way you don't get yourself in.
Yeah, I don't want to get in the fun, so.
Side to that task.
I think that's a good idea.
You good? Matt, are you good with that? Did you hear that? Over? Text? All right, are you good with that?
Yeah,
You
yes,
understand what we're
just so long,
proposing?
yes, just so long as, yeah, the term
All right.
appears that we work on the policy.
So I propose that somebody make a motion that we direct staff to implement this policy created by Crystal with the date of June 23rd, 2026, with the one sentence struck that we just discussed. And that going forward, they can make revisions as needed and keep us informed of where that stands when it's appropriate. So moved. Bob understood. Motion by Bob.
Second.
Oh, I thought Matt. A second by Matt. Discussion. Tell me your thoughts.
Okay, and that's just not what I thought I understood. I don't have a problem with it. I just thought we were being general about what the direction was. But again, so long as the terminus is us working on the policy, I am in favor of having something protected in the meanwhile to stop these.
So you're taking this
That's fine.
temporary policy, which we're asking them to implement immediately. And you guys are work behind the scenes to tweak it and whatever's needed to firm up the language and the thoughts. And then at some point, that will be implemented to replace this temporary older policy.
Does that match your motion, Bob?
Yeah.
Okay.
Okay, any further discussion? All in favor, say aye.
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 I too will vote aye. Anyone opposed? All right, so that motion to direct you guys to implement this immediately and then to work as a subgroup to tweak it has passed. All right, so now I would entertain a motion that immediately we encourage or we
I don't think we should do that. Let's.
okay, make them, somebody tell me what the motion should be about the pride flag.
Do we,
I'm not sure if we need a motion or a vote.
do we need to vote on this? Or is it just, I mean, if,
Well, I think it would show a sense from the board up that we're, we're on the record protecting the rights of every individual and inclusive and so forth.
Can we
So
just vote that we're on the record as that? I just want to be really careful that we're.
I'm hoping
doubling
that
the operation.
any motion can be made, even if it's just to send me home.
I'm fine with Erica's suggestion.
Yeah.
Like to recognize holidays or other events.
Say that one more time.
Many governing bodies vote to recognize holidays, time periods, or other events. This might be an opportunity to use a recognition type of a vote.
Yeah.
Bring up a
You want to phrase one just
framework for that. Because I feel like that is governance. I feel like saying, hey, go, hey, this or that, and being so specific is operations, and I don't think that's where we should be. Definitely.
excellent point. I agree 100%. So, but I welcome any sort of motion that acknowledges that fact.
A motion that we recognize the dignity and value of all human beings, and that we recognize that there are holidays that periods of time. Well, there are holidays sounds too short. So there are time periods recognizing and celebrating the dignity and value of all human beings, especially certain groups of. I'm getting really ready. Somebody else words. Matt, you're Black History Month.
Yeah, I don't know. I worry if we do it. I understand the thought behind this, but I worry it sort of smacks of all lives matter. I sort of think we need to sort of focus and say that during Pride Month, we recognize that in the healthcare, in healthcare, this LGBTQ plus people have traditionally been discriminated against, and then KVH is committed to respecting them, making them feel comfortable, providing them excellent care. So I like the idea of specifying in this case.
Respecting their dignity and their inherent value. I just think it's really important to have those words in there.
I'm good with that.
Somebody's going to have to write this down.
Or do you just want to charge Jason with the idea of make this happen?
What I want to know is that when we finish this discussion, the organization is free, if not compelled, to recognize this immediately, as immediate as you can make it. So what do you want from us to feel like you're empowered to?
I think I'm good.
Yeah. Consensus.
I have absolute full faith in Crystal, and her team will do what her group does, and they have not let us down.
So we can show this support, but it's got to come from the institution, not individuals.
Correct. And Crystal has the ability to create and amend policies, so she will have that in place. And then we have the opportunity to always amend policies and feedback, do that as well.
Okay.
Yeah.
Sounds good.
Does the board feel they want to put anything forward officially, or are you content with what you've just heard?
So I felt like Matt was on a good track there. And I don't like kind of half baking something and not finishing it.
Okay.
I agree with Erica.
I think he was.
Erica,
we talked about was
Good.
having Jason.
I trust you, Erica.
I'm not a decorator and I'm not a wordsmith.
No, you like that phrase. Why don't you just do one sentence? What about what was the phrase you had, Erica?
So I want to make sure that we have verbiage in there about respecting dignity and value. So, but I also take your point about I don't want it to be, nobody wants it to be diluted.
I mean, the dignity and value of LGBTQ plus patients and providers. I mean, it could be something as simple as that, and we want to recognize that.
Yeah. Okay.
Use it in a complete sentence.
The board recognizes the value, the dignity, and the value of the LGBTQ plus. Strike the providers and community.
And patients.
I don't want to be just limited to patients. Do we want to limit to patients?
Do you need to break it and just be community, which gathers it all, or do you need to break into individual? Not to.
Community's fine.
Community, okay, community, because that would be everybody.
So give me the sentence one more time now.
the KVH Board of Commissioners recognizes the dignity and inherent value of the LGBTQ plus community, period.
Do you have a copy of that? Okay,
And it's recorded.
okay.
This is true.
Does anyone in the audience have a comment about that thought? Again, it's just at the high level, we're just showing support. You know, are we missing something? Does anybody want to comment on the motion? We vote on it.
You can add, we celebrate Pride Month. Yeah.
Yeah.
I like that.
Yeah.
You want to wordsmith that into something?
I like yours, just last sentence.
Just say it in a, just say it in a, well, I need to hear it
And-
once in
is it
a
and?
sentence.
Is it and or is it a separate sentence? Because this is going on the record. We
And
need-
fine, yeah.
Okay. And we or KVH?
KVH, Kittitas Valley Health System.
Spell it out or KVH?
Well,
Spell it out.
Celebrates Pride Month.
Yeah.
And Pride capitalized.
So
Yeah.
when ready, if you can read the entire sentence in its continuous form, I would really appreciate
It
it.
changed up on me a little bit there, but the KVH board recognizes the dignity and inherent value of the, I'm probably gonna get this wrong, LGBTQT plus.
LGBTQ plus.
Okay, plus,
Community.
community providers.
Strike providers and community
strike
because
that.
that's redundant.
Okay,
Yeah.
and patients.
No, and strike that, just community.
Okay, just community.
Yeah.
And KVH celebrates Pride Month.
I think that's,
Now we have KVH in that sentence twice. Is it necessary to be in there twice?
it could be the board and then,
That's how it was first time.
yeah.
Okay, I'll leave it no board.
So when ready, read me the sentence. I'm sorry, I just have to,
Pressure.
oh wait, the helicopter's coming in, hang on. Let me get loud.
just
Gotta shout.
go.
Go fast now.
Okay. The board recognizes the dignity and the inherent value of the LGBTQT plus, right, you have that backwards. LGBTQ. Sorry, plus, and KVH celebrates Pride Month.
Community. You have it written there. You just.
Community.
And KVH celebrates Pride. You have it correct. So
Okay.
what is written, let me see it. Okay.
All right. We have a motion on the table.
Made the motion.
No, we don't. Okay.
Oh, wait, did you?
I'll make the moment.
So we have a first by Bob. Do we have a second?
Second,
Second by Matt. Is there any further discussion? Okay. All in favor of this motion in support of the community, say aye.
aye.
I too will vote aye. Is anyone opposed? Hearing none, that motion passes. All right. Is there anything you need from us to feel like you can get stuff that represents Pride Month up in a timely fashion?
Oh, I think we're solid.
Okay, is there anyone in the community that has anything else they'd like to say out there that we're not understanding or whatnot? That these two will be working to fine tune this document with Crystal. Crystal will be reaching out to people to make sure we're not missing anything in the actual verbiage. But I think we've got a little bit of legal protection, we've got a little bit of direction. So thank you for those who did attend for this cause. We really appreciate the input, the passion, helping us understand what we needed to understand. So thank you. Oh, yes,
Just name the flags going back up.
but it's going to be done through the hospital organization, not an individual.
So that it goes home.
So no individuals should be putting anything up. It's going to go through the organization.
Yes, that was really the question.
Great.
Good, as long as, okay. Any more policy discussion anybody would like to have tonight? Hearing none, okay, and just, so you know,
Wait, was that?
Oh, no,
You
not on
can't-
that. Before we go to the next topic, I had just a slight request from the board.
okay, go ahead.
The next agenda item is for board self-eval.
Yeah.
I was just gonna suggest if you wanted to offer to dismiss the executive.
That's
team.
what I was gonna do before you interrupted.
Sorry about that. I
So,
apologize.
so now that we've covered a lot of the topics that were important to people, anyone in this room is welcome to leave if you've had enough. It doesn't hurt our feelings. We're going to go on to some other board business and eventually some executive session to deal with some legal matters and so forth. But again, I thank everyone for attending and sharing your thoughts and your passion. It's very important to the board. So
What's your dog's name?
Likes to be colored lights.
Well trained. So.
Yeah, so we press this one. Oh, this. They should stay away.
all right, so we're on to old business, board self-evaluation. I know Jason had shared some thoughts in the last week or two or three. Jason, do you want to hit some highlights of what you're looking for from us here?
Yeah, I had shared with, I guess I did just to Bob and John.
Oh, I didn't know, just the two of us.
Sorry, from a board meeting ago. My task was to gather some.
The helicopter.
It shuts off when the helicopter comes in.
That's good.
Yeah.
You warm it up?
Cooler.
Even I'm not wearing the jacket, so it's gonna be posty in here.
6 o'clock.
Matt's having dinner or something. Okay.
Each year for the board self-evaluation, at least I only did one of them.
Oh, okay.
I only facilitated one of them last year and it was to seek information from the executive team, which was just open free form last year. What do you guys think of the board? Take a bunch of notes, send it to the board. So this year I had just suggested, I think I wrote out 5 questions to Bob and John sent the last board meeting. They were kind of the commissioners to bump things off of, sent them a handful of questions just to ask to the executive committee to spark discussion. I would take notes and then send that to the board. So it was just those 5 questions. I did not bring those though tonight. Happy to go print them.
No, I don't think that's needed. I think.
Or does that work for the board?
And that's, so I think we need to figure out from the board members. Jason, again, is thinking about reaching out to the executive team, getting feedback, consolidating that, sharing that with us. And then like we always do, we self-evaluate, we talk about, what we're hearing, things like that. So for the other board members, please share your thoughts on how you'd like to do the self-evaluation. Jason has one proposal. If you have something different or want to add or change it, please speak up, share your thoughts. How do you want to self-evaluate this year?
I like the proposal.
Okay, we've got one proposal is liked.
I'm good with it.
You too?
Okay, Bob.
I like it.
Good with it.
Okay. Good.
Yeah, I just wanted a few questions to spark conversation with the executive committee rather than just open and then.
I think both is good. I mean, specific questions and then just leave that blank box. Just tell us how to be better. What can we do to?
I mean, we really would, we want to be challenged, right? So we don't want. We just want to,
We don't want a bunch of softball questions that we know we're gonna hear great things about.
I mean,
Yeah.
really would like some input on what we can do better.
They're speaking for themselves. So, no, yeah, we're here to give it to us straight. What are things that, we can try better and learn from and grow and.
I'll put those questions out. We'll have conversation. We'll get some feedback and.
And then how you funnel the feedback to the 5 board members?
Prior years, I or a designee just wrote it up and then we had it at the board meeting.
The regular board meeting during executive session, so, okay. Is everyone content with that? And do you think it'd be a month from now, or might need more time, or just kind of take as it comes?
I think I could get it by the next board meeting.
Awesome.
So I have the questions and stuff, and it'd just be a discussion with the exec team and then.
And if not, just, it'll be a month later. You go as quick as you can go, so, yeah. But yeah, encourage them to be honest.
Y'all hear that?
And you don't have to be anonymous. We don't hold grudges or nothing.
Oh.
All right, so it begins. Anything else about board self-evaluation anybody wants to talk about? Is that enough for you? Enough direction for what we're doing? Okay.
Or you want to get on the next agenda then, or a special meeting like?
I would
Done
leave it
with
to
that.
Jason to say when he's ready to put it on the
Leave it
agenda.
on the next agenda.
Okay.
Okay.
And it will either be an update, or it'll be ready to go.
Okay.
How much time do we need for executive session tonight?
Oh, I just need, I'll try to work efficiently and say 20 minutes.
Okay, 20 minutes. And who needs to stay for executive session?
Just Jennifer
Okay, and yourself?
and me.
Okay, very good.
So.
All right, so I'm gonna read this first. We're gonna recess into executive session to evaluate the qualifications of an applicant for public employment under RCW 42.30.110 subsection 1, section G. And what do I need to say here?
The highlighted one.
Oh, and to discuss with legal counsel representing the agency matters relating to agency enforcement actions, or to discuss with legal counsel representing the agency litigation, potential litigation to which the agency, the governing body, or a member acting in official capacity is or is likely to become parties when public knowledge regarding the discussion is likely to result in an adverse legal or financial consequence to the agency.
Holy crap.
Okay. All right, it is 8:10. We'll take a 5-minute break and then we'll have a 20-minute executive session. So we'll come back in session at 8:15 p.m. for 20 minutes.
Are we cutting?
Mandy, please resend me
Yes.
the link. I don't see it in the thing.
I canceled it because something popped up saying that the meeting was gonna end in 10 minutes on the screen. So I'll go send a new
Okay.
link to both you and Andrea right now.
Thank you.
Okay, let me correct this. Let's take a 10-minute break. We'll get set up and whatnot, and then 20 minutes. So we'll reconvene at 8:20 for 20 minutes.
All right, thanks.
Thank you.